with many awareness webinars, awareness sessions on social media, news channels, newspapers. We are very much keen to know regarding how to prevent from COVID-19 and how can we treat and how can we diagnose it early. So we know so much things regarding COVID-19 infection, regarding its blood investigation, regarding its treatment options, regarding its preventive measures. We know so many things, but today we are discussing these things in little bit depth and some scientific basis, so that our students and other members can understand that what is the exact preventive measures and what are the exact symptoms and what are the basic treatment options. So start with natural history, clinical presentation and symptom spectrum. So first question is coming in our mind that after exposure to the COVID patient or exposure, how many days it can take for developing the symptoms. So these are few studies happened for that. That incubation period is median incubation period is around 5.1 days, and on an average it will take from 2 to 14 days for developing the symptoms after having infection. Symptoms may appear after 2 to 14 days. See, these are the primary symptoms of COVID-19: cough, shortness of breath or difficulty in breathing, nausea, vomiting or diarrhea, fatigue, muscle-like body aches, fever with chill, congestion, runny nose, new loss of taste and smell. So these are the few common symptoms regarding the COVID-19. These are the symptoms among the hospitalized patients. Most common fever, shortness of breath, fatigue.
All the participant, please mute yourself.
Cough, fever, shortness of breath, fatigue, confusion, sputum production, diarrhea, vomiting, muscle-like chest pain, headache, wheezing, abdominal pain, sore throat. So these are the most common symptoms, most frequent symptoms that we are seeing in our routine clinical practice in OPD patients also, in hospitalized patients also. Clinical presentations may vary by age and sex. Like ear, nose and throat complaints are more common in young patients. Fever, fatigue, loss of appetite and diarrhea are more common in elderly patients. The new loss of sense of smell and taste, headache, nasal obstruction, throat pain, fatigue are more common in the women, and cough and fever are more common in the men. So these are the studies happening in European countries, and this shows this kind of variation of symptoms in elderly population. Same thing, some laboratory abnormalities and radiographic abnormalities are also different. Mild patients, mild and severe patients. So that includes C-reactive protein, D-dimer, lactate dehydrogenase, enzymes. So these laboratory markers, industry markers may vary from mild to moderate and on severe patients. These CRP values, D-dimer values, laboratory reports are always our patients and always asking about the confusion regarding the elevated levels of CRP and D-dimer. So it is a very non-specific values, as CRP is a marker for infection and inflammation, and D-dimer is a marker of coagulation abnormalities. Non-specific values, and we should always think about the other differential diagnosis regarding these abnormal values. But based on pandemic scenario and based on our current patients in our hospital, we should always raise suspicion of COVID-19 in all patients. Laboratory values of these parameters. Same thing happens in the chest. So chest abnormalities, chest radiographic abnormalities Am I audible? Okay. Impaired diffusion capacity for carbon monoxide and diffuse and reduction of the exercise capacities during first 6 months following the discharge. That will that is the experience from last SARS-CoV pandemic in 2003. When this pandemic happens, the same. Yes, same scenario happened with the COVID, with the SARS patients, with the reduction of the reduced lung function capacity and exercise capacity. Like post-traumatic stress disorder, depression and anxiety are still common in. So my PPT is not moving. So in pulmonary sequelae on post-mortem observed the diffuse alveolar damage and platelet fibrin thrombi indicate the coagulopathy. So this is very important point because the cause of death and cause of mortality in COVID-19 patients is one of the reason is the coagulopathy, the platelet fibrin thrombi that is the responsible for mortality in COVID-19. Some long-term sequelae like pulmonary interstitial damage and some bony abnormalities are also there due to large doses of steroids which we are given in the COVID-19 patients. Some patients may came for admission after discharge due to reasons of the various respiratory issues, due to underlying lung issues, cardiac issues, neurological issues. So these are very common in COVID-19 scenarios. Some extra pulmonary manifestation of COVID-19, which we are seeing in our indoor patients also. Some manifestations are long-lasting and some manifestations are short-lasting. And these manifestations always are very threatful and very for life-threatening disturbances like thromboembolism. That includes deep vein thrombosis, pulmonary embolism, and catheter-related thrombosis. These are very common in severe COVID-19 patients and that may lead to increased mortalities. Neurological manifestations are also very common like headache, dizziness, encephalopathy, and other neurological diseases are also very common in severe COVID-19 patients. Some short-lasting extrapulmonary manifestations like kidney problems, liver problems, GI problems, endocrine-related problems are short-lasting problems that may recover after few months or few days or few weeks. Some cardiological cardiac issues like cardiomyopathies, cardiac arrhythmias, cardiogenic shocks, myocarditis, this can lead to increased mortality in our COVID-19 patients and that may last even after discharge or even after few months also. So some manifestations are life-threatening, some manifestations are short-lasting that we can treat it, and some manifestations with best available treatment still may lead to increased mortality in our COVID-19 patients. Cardiovascular sequelae, as we already discussed, neurological sequelae like Parkinsonism, dementia, depression, post-traumatic stress disorders. This is very common. Anxiety is very common in our COVID patients, and long-term neurological and psychiatric disturbances can happen. One more thing is altered or loss of taste or smell, like altered olfactory and gustatory dysfunction. That is new developing symptoms and which we are observing in our COVID patients, in OPD patients also and indoor patients also. Now, the most common questions among common people, layman people, and among all of us, that what is the exact surface viability and what is the exact duration that COVID can survive. So in aerosol, as an aerosol during coughing, sneezing, or during talking, aerosols, droplets of COVID virus can stay in nearby environment up to 3 hours. Same droplets, same fomites can stay up to 10 to 20 hours on the copper, up to 20 to 40 hours on the cardboards, up to 60 to 80 hours on the stainless steel. So this can guide us that cleaning, disinfecting all these surfaces in hospital premises, in clinical premises, that will prevent further spread of infection, and that is the reason that after having infection of one family member, all other family members are having positive COVID infection due to long viability of this virus on these surfaces that which we are having contact in routine our life. So that is the reason for increased infectivity and increased number of cases in COVID-19 pandemic. So this is a slightly different from swine flu, which have a aerosol transmission. SARS-CoV-2 is not airborne disease, not an airborne transmission, is only aerosol droplets or fomite transmission. So that is the matter of debate since last few months by WHO and other World Health authorities regarding the airborne transmission of COVID-19, and it is proven that it is not an airborne, it is a droplet or fomite transmission that which we that SARS-CoV infected patients can transmit to susceptible host. Environmental stability, which we already discussed. So with most commonly high viral shedding can happen from upper respiratory tract during coughing, sneezing or talking. We cannot culture virus in more than 9 days after the symptom onset. Multiple studies describe the correlation between the reduced infectivity with COVID with high viral loads and rising in neutralizing antibodies. So timing of SARS-CoV-2 transmission based on the symptoms. Before having knowledge regarding the transmission, which before and during initial time of the COVID-19 pandemic, we know that it might transmit from only symptomatic patients, but it is not true. Even asymptomatic patients can also transfer COVID infection up to 7%. So this is the very common that we cannot predict that this patient can transmit COVID infection or not, because in asymptomatic phase also patient can transmit infection to the others. This is also a debating topic regarding the surface viability, and this is the temperature viability. Many studies shows that increased temperature and increased humidity can kill the COVID-19, but this is no evidence regarding that, and it is not effective because India is a hot climate countries. Still, we have a large number of COVID-19 patients, so there is no effect of temperature and humidity on the COVID virus. This is the model regarding the SARS-CoV-2 transmissions. As we have an experience of pandemics in the past also, like HIV, TB, like SARS-CoV-2 in 2003. This is the potential models. Some countries are experiencing small peaks and small falls. Some countries are experiencing large peaks and large falls. And some countries are experiencing slowly small amount of patients throughout the months. So these are happening, as you can easily understand this model. Like there is a second wave of COVID-19 in European countries after fall from first peak. In India, we are right now facing a fall in our COVID-19 patients, but the authorities says that after festival season or in the peak winter, we again having experience of peak in our COVID-19 cases. So up to 2022, I think we should we have to live with with this COVID virus, and we have to apply the routine preventive measures which recommended by these authorities, like identify and quickly test the suspect cases, quarantine close contacts of the infected individuals, wash hands with soap and water, maintain the social distance, wear the cloth face cover mask in the public, practice the respiratory etiquettes that is very poor in our Indian population, disinfect frequent touch surfaces regularly, avoiding crowds, close contact settings and poorly ventilated spaces. This is very common in our Indian scenario, where small functions or small festivals can gather a large number of people, and that is the risk for spreading the COVID-19 virus. Regarding the disinfectivity, we already know that about 60 to 70% of the ethanol, 0.5% hydrogen peroxide, and 0.1% sodium hypochlorite is very effective in killing and inactivations of the SARS-CoV-2. So 0.1% sodium hypochlorite solution is very effective in disinfecting the surfaces and for inactivation of the SARS-CoV-2. Regarding the transmission of the SARS-CoV-2, for prevention aspects, we have two aspects of preventive measures, like in common people and like in the healthcare setting. In common people, there are so many misconfusions, myths regarding the use of mask, gloves, and eye protections, which we are discussing in detail later on. And in routine and in our healthcare settings, which is the biggest source of risk of transmission of the COVID. In that cases, we should use the proper N95 mask and proper aerosol generating procedures and all proper preventive measures, including PPE kit. So regarding the mask and respirators, first is a dust mask. A dust mask is the only mask for preventing the household dust, grass mowing, gardening, sweeping, fiberglassing, and during sandstorm. So dust glass cannot prevent against the COVID-19. It is only a simple dust mask which can use in our routine life. Second is a single layer face mask. Single layer face mask is made of single layer of non-woven fabric or wood pulp tissue paper, and is generally used in the food processing industry. It is used only for single use and should never be washed and reused again, and it is not effective against the COVID-19. Third is the triple layer surgical mask or medical mask, which are using by doctors, nursing staff, paramedical staffs, and other hospital staff. Surgical mask is actually contrary to the popular belief. Surgical masks were never intended to protect the surgeon from catching the patient infections. Actually, mask was always meant to protect the patient in case of surgeon coughing or sneezing during the surgery. So surgical mask can protect patient from surgeons. However, surgical mask does not protect the surgeon from blood spillings, body fluid splashes entering into their nose and mouth during the surgery. So surgical mask is a triple layer surgical mask. Outer layer is hydrophobic non-woven layer. Middle layer is a matte blown filter. Inner layer is soft absorbent non-woven layer. Triple layer surgical mask, there should be a proper method for wearing a surgical mask. Before wearing a surgical mask, always disinfect your hand with sterilium or alcohol-based hand rub. Then a proper fitting of the surgical mask over the nose bridge, and do not touch the mask in between. If you are touched by mistake, then disinfect with hands properly and change the mask after 6 hours. It is a disposable mask, not reusable, and it is preventive against the bacteria and various viruses. We can use in our routine non-medical persons also in our routine life. It is effective, but it is not sure that it completely protects against the COVID-19. Fourth is a respirator mask. It is an N95 mask, which is very common terminology which are using in our routine life, and which many people are buying N95 mask from the medical stores without having the proper knowledge of that N95 mask. It is a respirator mask. It is a tight-fitting mask with a filtration system that prevents the wearer from being exposed to the noxious particles, gaseous oils, microorganisms including bacteria, virus, and fungi. It is a two specific characteristic. It is an L-filtrating system that prevents the passage of noxious substances and microorganisms entering inside the respiratory tract, and it is a tight-fitting mask, so it is not having a leak from side of the nose and mouth, and it is effective against the COVID-19 other viruses size more than 0.3 micrometer size. Just like movie films are certified into the A for adults, PG for parental guidance, and UG for universal, depending on the amount of adult content, same like respiratory mask are certified into the N, R, and T, depending on the ability to offer resistance to the oil-based particles. So N stands for not oil resistance, and this mask can only be used for particles that do not contain oil. R stands for somewhat resistance to oil, which is a service life of about 8 hours, and T stands for strongly oil-proof, which has a service life of around 40 hours. So P and R are used only for industrial settings, are not relevant for discussion. And N is further divided into N95, N99, N100, depending on the filtration efficiency. So N95 means that this mask can filter of at least 95% of the particles more than 0.3 micron size. And N99 means it can filter of 99% of these particles. So this is the N95 mask. It is a standardized protocol set by the European authorities and US authorities. There is no standardized authorities having for proving N95 mask in our country. We are using these N95 mask in healthcare settings. So all other N95 masks are not equal to this N95 mask. So please take care before buying or before purchasing or before using this N95 mask. There is difference between filtered N95 mask and non-filtered N95 mask. This filtered N95 mask is used in the industrial settings, so it can spread the COVID-19 virus from one person to another person. Now, have some point discussion regarding the herd immunity. What is the herd immunity actually? Herd immunity is an indirect protection of susceptible individuals from infection to the sufficient portion of the population is immune. So when we are discussing regarding herd immunity in SARS-CoV-2, we should know about the herd immunity threshold. So point at which proportion of the population that is susceptible below the level for need of transmission. That is the herd immunity threshold. So this is the herd immunity concept. When one person can infect 4% and 4% can infect other 4 persons, this is the pattern of any pandemic. When herd immunity achieved, 1% can infect only 1% out of 4%, other 3 persons are immune. So this is the herd immunity, and this is the level herd immunity threshold level. So when the herd immunity naturally occurring from infections with a significant high mortality rate and high number of deaths. So if we discussing or if we want to achieve herd immunity in SARS-CoV-2, we need to face high mortality rate and high number of deaths. When disease is not uniformly lethal, then it may occur with the lowest risk of mortality also. We are using very much proper preventive measures and very strict non-pharmaceutical interventions like lockdown, like infection prevention controls that will decrease the ability to achieve or to enable the herd immunity. So we are not near to the herd immunity right now, but yes, vaccination resulting in a lasting immunity in all population, it is the most established effective way of establishing herd immunity. So we should wait for vaccination before achieving the herd immunity. Some questions are still questions like any protection from future infections after having first COVID infections, duration of protection, what is the duration of protections, and any protection against a serious illness upon the reinfections. So these are the questions still going on, and we have not any specific answers, any specific data or any clinical trial suggesting that about the reinfection. Our healthcare systems and healthcare providers, what can you do? So implement the standardized protocols and quality improvement initiatives and identify and address the racism that hinders the patient's care and communication. Means many times in our developing countries where lower socioeconomic class populations or middle class populations, sometimes they cannot have a proper healthcare system availability, and they cannot go to the healthcare system and diagnose their diseases properly. That can increase the risk of infections. So that we should do properly, and we should have a proper system regarding these diagnostic and therapeutic measures, which we have achieved very good in our country since last few months, and it is very appreciable from the government of India that we have a strong network regarding the diagnosis, regarding the treatment, regarding the free diagnosis and free treatment for the poor population that is very effective for preventing SARS-CoV-2 transmission. Now the screening and diagnosis. How can we suspect the patient? Any patient having acute onset of fever, cough, more than or equal to 3 days of the following, like fever, cough, generalized weakness, headache, myalgia, sore throat, anorexia, nausea, vomiting, diarrhea, altered mental status. With either he is living with the area with high risk of transmission, or either he has traveled within a high community transmission area, or any working in the healthcare setting. So we can suspect COVID-19 infection in this scenario, or any patient with acute respiratory illness came with the hospital with no identifiable other diseases. We can suspect COVID-19 in any acute respiratory illness with a history of fever and cough with onset last 20 days. Now the probable case. What is the probable case? With the same symptoms and contact of any patient or any person in epidemiological clusters, we can suspect as a probable case, or any suspected case with a chest imaging showing findings suggestive of the COVID-19 disease. Sometimes symptoms may appear later, but CT scan showing COVID-19 disease, or recent onset of this loss of smell or taste in the absence of any other identifiable symptoms, or unexplained death in adult with respiratory distress, which was contact from the confirmed case or epidemiology linked to the cluster within a 1 month. So also in all these scenarios, we should always suspect the COVID-19. I am not discussing detail in the diagnostic measures, as we have a separate talk on diagnosis of COVID-19. But few slides I am going through regarding the virus nucleic acid assays, like which we are calling RT-PCR, that indicate the correct infections, and we can take samples from upper respiratory tracts, lower respiratory tracts, and it is a primary method for COVID-19. Sometimes false negative results from improper sampling, handling the samples, low viral loads, or viral mutations, or in many cases SARS-CoV RNA undetectable by day 14. Antibodies. It generally indicates the past infections, but may have some utility in the diagnosis of current infections, particularly in the second or third week of infections. It can provide a delayed but wider window of time of detections, may be useful for surveillance measures and identifications of the convalescent plasma donors. False negative maybe in the first week, false positive due to cross-reactivity. So due to negative results are mainly due to the poor sample quality, timing of the specimens, very early or very late, specimen was not handled properly, or some technical reasons. These are the reasons for negative RT-PCR reports. Their Center of Disease Controls, USA, have some recommendations for SARS-CoV-2 that we should do test in any patients with the COVID-19 symptoms, or also do test in the vulnerable populations or close contact populations in high transmission areas. Those patients who are working in the nursing home or long-term care facilities, or living or receiving care in the nursing home, or in healthcare workers. This all population we should test RT-PCR as early as possible. In non-hospitalized patients, if the test is negative, there is no need to do repeat test. But in hospitalized patients, if the test is negative, then we should take the second test, either if possible from the lower respiratory tracts in the form of lavage or sputum. In known exposure or in high prevalence area also, we should do repeat testing if first test is negative. In low suspicion area, there is no need to do a second test. SARS-CoV-2 generally high viral load we are seeing in the saliva, but still we are facing many negative tests. In that case, lower respiratory specimens, endotracheal aspirates, bronchoalveolar lavage can help us to diagnose the SARS-CoV-2. High viral load which we are seeing in the nasal swab, throat swab, but highest viral loads in the sputum, lower respiratory tracts, which is documented, but we are not using it due to some technical issues in all patients. Sensitivity, specificity, as we discussed, upper respiratory, upper respiratory sensitivity of around 76%, lower respiratory sensitivity around 89%, specificity is 100%. So if any suspicion, if first test is negative, we should always take sample from lower respiratory tract, or we should always assess clinically or by other means like CT thorax. CT chest abnormalities is always pick up the COVID-19 in very early stage. We can diagnose very early, and we can start, and we can have a quarantine facilities early based on these CT chest abnormalities, even in the COVID-19 RT-PCR negative case. There is some data regarding the SARS-CoV-2 in the stool also, and that may remain viable up to very long time. But we are not using this diagnostic method. This is only for surveillance or epidemiological purposes. This is the graph showing the viral load PCR positive status in various weeks. Before symptom onset, detection of SARS-CoV-2 is unlikely. After having a symptoms onset, nasopharyngeal swab is positive up to third or fourth week. Bronchoalveolar lavage is positive up to the sixth week. Stool RT-PCR low viral load positive up to the sixth week. IgM on antibody can start appearing from second week up to the sixth week, and IgG antibody start appearing from second week up to the sixth week. So this is the temporal consideration for the diagnosis. Antibody responses. Various methods for SARS-CoV-2 antibody test, not going into detail, but this is important for planning for convalescent plasma donors, neutralizing antibody titers. Neutralizing antibody titers and spike binding antibody titers are various, is not uniform. There is not strong any data regarding the value of neutralizing antibody titers, which we consider protective and which we consider to give plasma donation from one person to the another person. But still it is an experimental and still it is in a trial basis. We are not having a confirmed US FDA approval or any government of authorities approval for having a convalescent plasma treatment in COVID-19. So learning from other epidemiology, two-step diagnosis by serology, early diagnosis of HIV with ELISA, and we confirm with the Western blot. Same thing we can step with in COVID-19. We can diagnose with RT-PCR. Later on we do SARS-CoV-2 antibody. This is a chart showing how can SARS-CoV infect our immunity and our immune system. Our innate immune system first is affected, then our adaptive immune system is affected. That can lead to cytokine production. Killing T regulatory cells can regulate the inflammation. Cytokines cells can killing of the infected cells and induction of the antibodies. So it will take from 1 to 2 years to have a developing the antibody. Antibody decline after 2 to 3 months, as this study is showing. There are few cases having COVID-19 reinfection also. Our country is not having any case of COVID-19 reinfection, but few documented cases in the Hong Kong and in China having COVID-19 reinfection. Now the current medical management and supporting measures. WHO and NIH have a specific guidelines regarding the treatment and isolation protocols, and when to start treatments, and when to interfere and when to admit the patients. Based on the mild symptoms, बात करेंगे हम 15 मिनट 25 साहब फोन करें. Based on the severity of the disease, we are giving based on hospital-based treatment or home-based treatment, and we have a very good protocol, and we are following these our routine clinical practice. Based on the severity of the symptoms, we advise the patient for admission, and also advise for the basic investigations like chest X-ray, ultrasound, ECG, WBC counts, inflammatory markers, or even CT scan. We are using liberally right now to diagnose early and interfere early. Severe pneumonia treatment, but obvious that severe pneumonia treatment patients need admissions, and he need oxygen support and various other supplementary measures like ventilatory supports and urgent management regarding these critical conditions. Some critical patients regarding need for prevention of complications like ventilator-associated pneumonias, venous thromboembolism, catheter-related bloodstream infections, stress ulcers and GI bleeds, and antimicrobial resistance. This is also very common in our routine practice, even in the non-COVID scenario. After prolonged ventilation supports or after prolonged critical illness, this all problems can lead to mortality and long prolonged hospital stay and increase the cost of the treatment. Medical management, I am not going to discuss into detail, but it is the protocol which we are using in our patients with fluid therapies, with vasopressors in the septic shocks, considering the identification of the renal dysfunction, hematological dysfunction, and we are interfering early and start treatment accordingly. Thrombosis, thromboembolism is very common in COVID scenario, and we are experiencing many mortalities in thromboembolism, venous thromboembolism patients, despite of giving best treatments. So this still is unsolved question for our clinicians. Discontinuation of the treatment more than 24 hours of the fever or any improvement in the symptoms including cough, shortness of breath, or more than 10 days since the onset for mild to moderate illness, more than 20 days for severe to critical illness. So more than 10 days if patient is asymptomatic and improvement in the symptoms, we can discontinuation the treatment, or more than 20 days in severe or critical illness patients. There is no need to do a SARS-CoV RNA repeat testing in patients to confirm that patient is non-COVID or not. So there are laboratory predictors for thrombosis: increased D-dimer values, increase the 5-linogen values, increase the CRP values for prediction of the thrombosis. So there is a terminology called thromboinflammation. So in COVID, there is a thromboinflammation is going on that will lead to thrombosis in pulmonary vessels, deep veins, lower limb vessels, and that can lead to pulmonary embolism and other complications, and that will increase the mortality. And then reason for that is endothelitis, endothelial infection, vascular endothelitis, endothelial dysfunction, altered blood flow, and platelet activation can lead to this virtuous triad in COVID-19 and lead to thromboinflammation or thrombosis. Anticoagulant therapy, we are using anticoagulant therapy in all patients suspected of with thrombosis and with good results, and with the increased early use of the prophylactic heparin or low molecular weight heparin can definitely decrease the mortality. Even in a therapeutic dose also it will decrease the mortality. When considering the COVID-19 scenario in your adult population also, it is very important to discuss in the pregnant population and children population. Treatment protocol is same, but in pregnant populations we have experienced increased number of cesarean sections as compared to normal deliveries, and we have to observe the baby for any preterm complications or any positive COVID-19 transmissions from mother having COVID-19 during pregnancy. Remdesivir we are not using in routine pregnant patients having COVID positive, but in patients who are critical and those who patients require oxygen support, US FDA approval for early emergency use, compassionate use for remdesivir in pregnant patients also. Mother to child transmission is documented in few patients and few cases also having neonate positive soon after delivery, and his placenta, mother's placenta was also showing inflammatory changes, and that neonate is gradually recovered and discharged after 18 days. This is a case study from transplacental transmission of SARS-CoV-2 infection. Management is almost same as compared to adult. Only thing we have to avoid some medication that is harmful in pregnancy, like hydroxychloroquine is not effective. Systemic corticosteroid we are using only in critical patients, and remdesivir on the compassionate basis on severe COVID-19 basis patients. What is the immune response of SARS-CoV-2 after getting infected? If with a low virus titer, then many patients are mildly symptomatic and recovered on their own immune system. That is called our adequate immune response. But many patients having a high virus titer, having monophage macrophage activation, that will lead to cytokine storms and increased lung injury, septic shock, organ failure, and coagulopathy due to inadequate immune response, and that will lead to more severe disease. So with this talk, we can easily assume that our immunocompromised patients are highly risk for having a COVID-19, like transplant patients, renal transplant patients, lung transplant patients, cancer patients, those who have weaker immune systems like diabetes patients, HIV patients, those patients on corticosteroids. All these patients have increased risk of having COVID-19 infection, increased risk of having a severe COVID-19 infections, and increased case of mortalities. So we should diagnose very early in these patients, and but proper quarantine or proper isolation facilities should be there for treating these patients. So same thing as we discussed in children, we are using remdesivir only in the few special cases. Otherwise, we are not facing many mortalities or many number of cases in children in last 4 to 5 months. So many children are recovered with the symptomatic treatments and with home-based treatments. Very few children need hospitalization and very few documented deaths in children. So that is very good for us that children are spared from this COVID-19 partly. Some patients, some children are having experience with multi-system inflammatory syndromes, documented 2-3 cases, not documented in our country, but in other countries, and that is after COVID-19 infection that will increase the inflammatory syndromes, and that is also treating by supporting measures. Now let's go into treatment overview. We already know that we have not any strong anti-COVID treatment, but we are all using under investigation treatment and on the emergency use approvals from the government. Based on that, there are options like baloxavir, convalescent plasma, favipiravir, hydroxychloroquine, interferon, lopiravir, ritonavir, intoxanide, oseltamivir, remdesivir, ribavirin. These are the antivirals. And immunomodulators are corticosteroids, IL-1 inhibitors, IL-6 inhibitors, tocilizumab, which is very famous name among non-medical person also, intravenous immunoglobulins and JAK inhibitors. So we are using all these drugs depending on the stage of the treatment. In early stage, early infection phase, viral responsive phase, patient is having fever, dry cough and lymphopenia. In that case, only symptomatic and supportive treatment. In stage 2, where patient is experiencing shortness of breath, hypoxia, abnormal chest imaging, or abnormal inflammatory markers, in that phase we are using remdesivir. And stage 3 is a hyperinflammation phase where host inflammatory response is very high. In that cases, many a times we are using dexamethasone, means steroids, oxygen support along with remdesivir. So we are treating the patient based on the symptom phase and same based on the investigations and clinical aspects. So IDSA recommendation for treatment is hospitalized patient with severe COVID-19 is remdesivir and glucocorticoids. For hospitalized patient but not severe, in that cases there is no meaning to use remdesivir and glucocorticoids. Same guidelines also from other institutes or other healthcare authorities that only use remdesivir with severe COVID-19 patient with supplemental oxygen. There is insufficient data in mild to moderate cases. There is no strong data regarding the hydroxychloroquine, which we are using in early days, but right now we are not using hydroxychloroquine. There is no data against the use of hydroxychloroquine. Immuno-based treatment, same thing, dexamethasone, glucocorticoids, which we are using in mild, moderate to severe patient with oxygen requirement. It is not used in mild cases without oxygen requirement. And there is insufficient data regarding the IL-1, IL-6 inhibitors, like tocilizumab anakinra in cytokine storm patients. Regarding the discussion of the remdesivir, it is a nucleoside analog of ATP that inhibits the SARS-CoV-2 RNA polymerase admission patient by competing with ATP for inclusion into the nascent RNA. It can delay the chain transmission during the viral RNA application. It is a only FDA emergency use authorization permits the emergency use of this unapproved product of remdesivir, which are using in our adult and pediatric patients in hospitalized cases. So it is an unapproved product, but it is a FDA emergency use authorization. So before starting the treatment, always explain the patient and his relatives regarding this scenario that we are using on emergency use authorization. Dosing of adult and pediatric patients more than 40 kg, 200 milligram day 1, followed by 100 milligram from day 2 to 10. And pediatric patient loading dose is 5 milligram per kilogram day 1, followed by maintenance dose of 2.5 milligram kilogram from day 2 to day 10. Also, we can use in pregnant patients also, but there is no adequate and well-controlled studies in pregnant and nursing mother patients. Pediatric patients also, there is no well-controlled studies. Geriatric patients, old age patients more than 65 years, it can cause complications. In renal impairment and hepatic impairment patients, it is also not recommended to use remdesivir, and always watchful for renal and liver functions during use of remdesivir. There are limited clinical data, so serious and unexpected adverse event may occur that we have not experienced previously, because it is used in an Ebola virus pandemic and we are using in COVID-19 first time. So we can have very limited data, so there is maybe some chances of high risk of infections. Okay. You can stop me if time is not permitting for extending this talk. You can interrupt me in between also, and you can ask me questions in between also. There is a form filling fact sheet for patients and patients' caregivers before giving the remdesivir, providing the information regarding the remdesivir. Second dose is dexamethasone. Dexamethasone is a corticosteroid with anti-inflammatory effect that has been used to treat allergies, asthma, dermatitis, rheumatic disorders, multiple sclerosis, and other autoimmune disorders. Means this dexamethasone we are using since many decades, and now it has a role in COVID-19. But at the same time, dexamethasone can cause elevation in the blood pressure, left ventricular free wall rupture in patients with recent MI, retinocortical insufficiency, increased susceptibility to infections, cataract, glaucoma, and damage to the optic nerve. So these are the side effects of dexamethasone high dose. There is a famous recovery trial from UK showing the clinical improvement of the COVID-19 patients after using dexamethasone, and that will decrease the overall mortality, and that will decrease the overall hospital stay after giving dexamethasone. There is a study recovery trial enrolling the patients owing the SARS-CoV-2 positive patients. This is a common characteristics of the patients in recovery trial. This is the previous disease of the patients after enrolling into the critical recovery trial. And these are two arms. One arm is the dexamethasone plus usual care, and second arm is the only usual care. And also there is a one arm having no oxygen, and second arm is on oxygen only. So after enrolling the patients, they have monitored that those patients who have on dexamethasone plus usual care have a mortality benefit, but only in the patients having oxygen support. Those patients who have no oxygen support, there is no mortality benefit with the dexamethasone. So same thing in mechanical ventilator patients, there is a strong mortality benefit with dexamethasone, and with oxygen support patients, there is a mortality benefit with dexamethasone plus usual care. So recovery trial shows that addition to the dexamethasone can reduce the hospital stay, can reduce the mechanical ventilation, and overall hospital cost burden. Secondary outcome of the recovery trial showing discharge from the hospital within the 24-28 days is also better after using dexamethasone. So dexamethasone panel recommends the use of dexamethasone 6 mg IV or orally for 10 days, or we can use other equivalent glucocorticosteroid like methylprednisolone, prednisolone, or any other steroids. But before starting steroids, always take the proper clinical history or the background clinical condition, and always assess the risk for side effects of the steroids. Remdesivir is not a part of the recovery trial, so we are not knowing that combination of the remdesivir with dexamethasone is effective versus dexamethasone alone. But yes, we have experience, and we are using remdesivir plus steroid combinedly in our patients, and that shows clinical improvement very fast, and early recovery and early discharge from the hospitals. Now, considering the convalescent plasma, there are three types of antibodies, monoclonal antibodies, which we are producing in the laboratories. Hyperimmunoglobulins is derived from plasma, is standardized product, and third is the convalescent plasma from the infected individuals, and it is the best to batch variability. So donor recovered from the COVID-19 can donate the plasma to the patient with COVID-19 with compatibility. ABO compatible should be there. There is a various studies showing standard treatment for convalescent plasma, standard treatment alone, that there is a mortality benefit in moderate to severe cases after giving the convalescent plasma with the standard care, and it can decrease the viral nucleic acid negativity after 72 hours, and it can discharge the early patients from the care. Second thing that con-COVID trial is also showing the same thing, but only thing that early termination of the clinical trial, so we cannot have a proper judgment from this clinical trial. FDA emergency use authorization for COVID-19 clinical convalescent plasma, clinical evidence and showing that convalescent plasma should not be considered as a new standard care for treatment of patient. Clinical evidence supporting was not promising, and for that we need well-controlled randomized clinical control trials before using convalescent plasma in our routine patients. It can lead to some potential adverse events also, like transfusion-related infections, allergic anaphylactic reactions, hemolytic reactions, TRALI, transfusion-related acute lung injury, hypothermia, metabolic complications, post-transfusion purpura. So all these potential adverse events are there. So we are not using convalescent plasma in our routine COVID-19 patients treatment protocols. Some investigational treatments are also there, like tocilizumab. Early days of COVID-19 pandemic, we are using tocilizumab, when not very promising molecule, can lead to sometimes secondary.
Yeah.
Right now we are using in very limited number of patients tocilizumab, very limited number of patients, IL-6 inhibitors, and in very selected cases we are using tocilizumab. These are the experimental drugs, still on the clinical trial phase, and not available in the market for treating the COVID-19. May available soon after having promising results. Thank you. So my talk is completed. You can ask me any questions regarding treatment protocols, regarding any testing protocols or any infection protocols. Am I audible?
Sir. Thank you, sir. Sir, there are few questions in the chat box, so I'll read one by one.
Yes.
Some of the patients with COVID die of cardiac arrest.
Yes.
This is asked by Dr. Sheikh Adil Hania.
Okay. The reason is that I have already discussed that long-term sequelae of COVID-19 can lead to myocardial ischemia, myocarditis, and cardiomyopathies, and that can lead to cardiac arrest. So that is the reason for more number of cardiac arrest in particularly old age populations, and those patients of population, those having associated comorbidities like hypertension, previous history of angioplasty, previous history of bypass surgery. In all these cases, increased number of mortality due to cardiac arrest.
Now the next question is by Dr. Bhavita Dhruv. She is asking that whether donating plasma put the person safe of getting COVID-19 again.
Yes, I have discussed that before transmitting plasma, we should titer the neutralizing antibody titer in the plasma, but there is no standardized value regarding the neutralizing antibody titer from the authorities. So we are transmitting the plasma only on the basis of COVID patients' history, background clinical history, and COVID antibody positive status. But there is no specific guidelines regarding the value of the antibody titer. Above that is effective, and same not having strong clinical trials showing a positive effect of plasma therapy in COVID patients. So it is not sure that plasma is effective in COVID patients, but still it is experimental and need more clinical trials.
Next question is from Dr. Maitri Zaveri.
Yes.
Once we are COVID positive, how many % of chances to become infected again? And she has also another question: which drug is more effective, remdesivir or favipiravir?
Yes.
And why?
Yes.
And why?
Yes. Yes, okay. So this is the common question among the all patients also and all healthcare population also, that after infecting COVID-19, is there any chance of having reinfection? Yes, there is a chance of reinfection is there, because there is no strong data showing the antibody present in the body, long-lasting antibody is there. Many a times we have observed that after 2 to 3 months, antibody level is reducing in the patient's blood. That is more prone for reinfection. But till this last 6 to 5 experience, we have not seen any reinfection patients, and we have not seen any reinfection critical patients. So even after reinfection, there might be chances of mild infection, not severe infection. Second question is what is effective, favipiravir and remdesivir. So both drugs are used for emergency use authorization by US FDA for treatment of COVID-19. It is not a drug for COVID-19, it is a drug for Ebola virus, which are using in Ebola pandemic before many years. So, but yes, remdesivir is more effective than favipiravir in moderate to severe patients. Favipiravir is effective for mild to moderate cases in home quarantine patients, in OPD patients. Favipiravir is effective. The mode of action is different. Both molecules have different mode of action. Mechanism of action is different. So remdesivir is more effective than favipiravir in hospitalized patients.
There is another question from our student.
Yes.
Whether natural mutation in COVID-19 is prevented by any medicine?
No, there is no medication that preventing natural mutation that we have seen in our H1N1 swine flu antigenic drift that is responsible for reinfection, and that is responsible for changing patterns of H1N1 epidemics and changing seasons of H1N1 epidemic. So that can possible in SARS-CoV-2. That is the reason the epidemiologists predict that, and WHO is also predicting the SARS-CoV-2 till the end of 2022. Even after having the vaccination, it can possible that mutations also occur in COVID-19 virus, and that will increase the risk of infection.
Another question is, sir, why many people are asymptomatic?
Many people are asymptomatic because their natural immunity response, mild cases after having exposure, small time of exposure, and good immunity, no background clinical conditions, that patients are treated and recovered with their own immunity and symptomatic medications. These patients don't require hospitalizations. So based on our immunity, based on our background clinical conditions, that will decide that how COVID-19 affect our body.
Another question from Dr. Sheikh Adil Hamid. He is asking whether this rapid antigen test in diagnosis is authentic or not.
Rapid antigen test diagnostic is effective, particularly for screening purpose, particularly for large scale purpose, particularly for screening purpose, particularly for early diagnosis. But it is not a gold standard test for diagnosis of COVID-19. Gold standard test is RT-PCR. But as we know, in our country with large number of population of at least 138 crore population, it is not possible to do RT-PCR in large scale. That is why government is doing COVID rapid antigen test free of cost in compassionate basis and always also providing CT thorax facilities in free of cost by our government in patients, those who are suspecting the disease, but rapid antigen test is negative. So we have options of having other diagnosis. But yes, RT-PCR is not possible because kit is costly, and facility and trained staff, trained doctors are not available in peripheral populations, peripheral centers. So in that cases, rapid antigen test, which we are using, is a good option.
There many questions are coming now.
Yes.
I'll send these questions to you. You can reply to me so that I can transfer this to the students.
Yes.
Okay, sir. So I request Shashikant sir to deliver.
We thank Dr. Kalpesh Panchal for spending his valuable time in educating us and clearing most of our myths. Thank you, sir. Thank you very much for sparing the time.
Thank you.
And many students are thanking, chatting that thank you, sir, and very nice explanation, etc.
Yes. Thank you very much.
Thank you very much.
Opportunity. Thank you very much. Yeah.
Now I request Dr. Anjali Padiyar to introduce the next speaker.
Good morning to one and all present over here. I feel greatly honored to introduce our second speaker of the day, Dr. Madhvi Joshi, who is currently serving as a Joint Director at Gujarat Biotechnology Research Center, Gandhinagar. She has completed her Master's and Bachelor's as a gold medalist from Saurashtra University and has also acquired her PhD degree from the same. She has a 2-year academic experience at Christ College, Rajkot, and has worked as a sector specialist at GHBTM for 6 years. She has a wide area of research interest, which includes genomics, transcriptomics, metagenomics, microbiology, and healthcare biotechnology. She has a great research experience of more than 11 years and also has a gain experience of more than 10 years in administration. She has been a successful PhD guide of 2 students and MPhil guide of 9 students. She has 12 international and 5 national publications, including a patent on her name. She has also contributed as an author in 14 books and a magazine. She has made through 9,353 NCBI submissions. She is currently handling many research projects having a total funding of 38 crores, international project having funding of 200 crores, which is funded by UK Research and Innovation, Government of UK, as well as a project funded by Forest Department of Gujarat of around 35 lakh. She has completed 29 projects related to genome, metagenome, and transcriptome sequencing. Thank you, Dr. Joshi, for being a part of this webinar. It's a great pleasure for all of us to have you here. Thank you. Now would like to invite Dr. Joshi to continue the session.
So very good morning, everybody, and thank you, Dr. Anjali, for a nice and elaborate introduction. Also to Dr. Shashikant for inviting me to be a speaker on this seminar. So mostly I assume that these are the students, and that is how I have started, my topic with a very basic idea of how we are moving ahead with the condition like pandemic. So for most of our generation people, pandemic is kind of a only textbook word, unless you know the December of 2019 when we first heard about the unknown infection that emerged in China, and slowly in less than a 6 month, it became a pandemic. And we all are experiencing, the different aspects of the pandemic in every field. So I thought that as a GBRC, most of you would be knowing that we are under Department of Science and Technology and Government of Gujarat. The core mandate of this center is to do translational research for any societal challenges. And COVID is one such challenge that appeared in front of the mankind. And as a GBRC, we thought that what we could do in this pandemic. So again, government had also requested that what activities can be undertaken. And most of you would be knowing that the strength of GBRC is into genomics. And that is how we started initiating the COVID genomics program. And slowly, GBRC initiative became a part of the national as well as international initiatives. And overall, how with the help of genomics, we can track and tackle this pandemic situation. That is what is the talk that I would be talking today. So let us go into the slide. So we all know that these are the number of confirmed cases that we are seeing here globally. And as you see the dark blue color, that indicates the intensity on a higher scale. And more than, this is the data of 19th October, and we have almost 3.9 crore confirmed cases across globe and almost 11 million deaths as reported by WHO. Again, if you look at the death distribution, it is on a very higher side, that as you can see, and almost no country is left unaffected with this pandemic, technically speaking. Now, how this pandemic has progressed across globe, if you would see here, so then you would see that in magenta, whatever is highlighted, that is mainly due to the community transmissions. But wherever you are seeing these yellow clusters, those are basically cluster of cases. That means, there are people transmitting the disease in their nearby clusters, and then that is how the disease is progressing. So in currently India, we are into the cluster transmission cases. If you look at the continent wise, that Africa is the least affected and America is the highest affected continent. Asia and Europe also is badly affected over the COVID, as you can see. These are again the death which are observed across continents. And as you can see that the highest number of deaths are being observed in USA. And that has continued over a period of 6-7 months, where the number of deaths are higher in USA. Previously, they were higher in Europe. And India is somehow doing better in this pandemic. And we would also explore in my talk further that how we are doing better in this. So if you look at the data, which is before 2 days, this is the case status where, USA has the highest number of cases, followed by India, Brazil, and Russia. And the number of cases are still increasing. So there are a lot many rumors, going on about the strain, what type of virus it is, how it is changing, how fast it is replicating, how fast it is mutating, whether it is, whether it is going down or whether the infection is coming fast. So all these things we can interact and counter with the genomics. If we talk about the mortality rate, so for that we have to first understand how the disease is to the mankind or to the host. So what are the parameters to assess it? So one is, of course, the mortality rate. So if you look at the mortality rate, as you can see that it is higher with reference to the age progression. If there are other health conditions, for example, if you have any cardiovascular issues, diabetes, respiratory issues, and hypertension, then the death is more. And of course, in male, it is observed to have more deaths as compared to female. Now, coming back to how contagious it is, So for understanding this, we will also have to understand one terminology, which is also very well known, and people would be knowing it as considered as R naught. Now, R naught is basically that how many cases of a disease an infected person will go on to cause. That means if one person is infected, it can infect how many other number of individuals. So if you would see that the mankind has seen some of the deadliest virus, for example, measles, which had the highest R naught, as you can see here in the circle. The light orange is the infected individual, and nearby circle, we have tried to show that how many other person that person can infect. So measles has the highest R naught, something near to 13 or 14. That means one person infected with measles can infect 13 to 14 individuals. Followed by, you can see that smallpox and rubella, they have almost similar R naught. The brothers of COVID-19, that is SARS and MERS, if you would see that they also have relatively higher R naught as compared to COVID-19. So this novel coronavirus, according to the different time period, and as the study done by an Imperial College of London, the R naught is estimated between 1.5 to 3.5. In some of the regions, the R naught values have been observed higher than that. So technically, this disease is very less contagious. And so as a part of evolutionary strategy, if a pathogen wants to stay in the host, they don't want host to die so fast and so soon. Otherwise, the disease will also die. So in a way, COVID-19 is a smart virus where the R naught is very less, so that it can infect, although the less number of people, but it causes less mortality. And that is how the spread has gone over the continents and over the country boundaries. Coming back to that, if we are talking about the case fatality rate, so Ebola had the highest case fatality rate observed so far, in which, there are 50% chances if you are infected with Ebola, then you will die. In MERS, it was 34.4%. In smallpox, it was 30%. In SARS, it is 9.6%. And if you're looking at the COVID-19 so far, it is around 3.4 to 4%. That means, and it is again, decreasing. So this is the case fatality rate of COVID-19 is relatively very, very less. Now, when we are talking about a virus, everybody has been talking about the virus and virus strain. In terms of bacteria, it is very classified thing to, define and strain that which should have, some functional changes, and it should have some attributes, some genetic changes. But when scientists use the word strain, they are actually referring to a genetically distinct virus lineage, which is distinguishable by one or more mutation from the another strain. And these strains may or may not be biologically distinguishable from one another. But some of the virologists, they've also termed strain only for the former. And the former one is that it should have genetically distinct lineage. Two strains would be biologically different if they elicit different responses from the human immune system, or if they varied in their transmission characteristics, what we have described so far. And when we are talking about viral mutations, because typically virus is an organism which is going inside the host and it uses host machinery and it replicates itself very fast. And now when the replication is taking place so very fast that everybody knows that there are errors also that occur. But when a virus is making its copy, then they again convert themselves into an RNA molecule, because COVID-19 is an RNA virus. And then the more complex organisms, we have a variety of proofreading mechanisms for ensuring the higher fidelity replication. But RNA viruses, they have particularly error prone and relatively rapid accumulation of mutations over a period of time, because for SARS-CoV-2, some proofreading enzymes and its mutation rate is lower than many other RNA viruses, for example, such as influenza or HIV. So what an genomic sequencing can reveal typically? So when we are doing the genome sequence of any individual, or here in this case for COVID-19, genomic sequence can help us understand the disease and how it is spreading, how virulent it is, how it is transmitting. It also helps us understand that how it is interacting with the human host, what are the interactions of these novel virus proteins with other proteins of humans, and what are the impact of drug treatments, diagnostics, and vaccines when we study the genomics. Whether these strains are different, or the strain is mutating, or how it is rapidly changing globally, that is the information that we can understand with the genome sequencing. And it will also assist in response to any future pandemics, because we would be prepared that how we can develop best mathematical models based on genomic sequencing and other epidemiological information to understand the transmissibility of the pathogens. So coming back to this SARS-CoV-2 genome, the genome is typically around 30,000 base pairs, and it is an RNA virus. Technically, it codes for a number of proteins, but important proteins are nucleocapsid protein, envelope protein, the spike protein, and other functional enzymes, for example endoribonuclease and RNA dependent RNA polymerase, as well as it has the 5' 3' UTR. So this is a typical genomic layout of SARS-CoV-2 genome. And ORF1ab is the largest. If you can see, it starts from 266 nucleotides up to 21,555. So that's the largest genomic region on the SARS-CoV-2 genome. When we have to do the viral genome sequencing, I would like to go back a little, older. That is in the early week of April, when the lockdown was imposed and we were to start the virus genome sequencing. The challenges for the virus genome sequence is that because it's an RNA virus, or even if it is a DNA virus, mostly the quantity of that DNA or RNA in the host cell will be so very less that you cannot enrich it and make a sequencing successful out of it. So at that time, when we did the first SARS-CoV-2 genome, we had sequenced couple of strains from a very low CT value patients. When you say low CT value, that means they have a higher viral copies or the viral load. In that case also, around 90 to 95% of the sequences were observed was of the host. So it becomes very, very difficult to track or first extract the SARS-CoV-2 RNA material and then do the sequencing. So currently in GBRC, the technology that we were using for SARS-CoV-2 genome was, one is of course Illumina that everybody knows, and second one is a Thermo Fisher technology. So in Illumina technology, basically what you are doing is that you do the genomic RNA isolation here in this case and convert it into a cDNA. And then what you do is you basically use some of the probes, which are capture probes. And that is binding at a various locations on the SARS-CoV-2 genome. And that probe actually captures these sequences and then you sequence them. So that is how you enrich the virus genome in your sample. In case of Thermo Fisher technology, it is a PCR based technology wherein you have the different sets of primers spreaded across the genome of SARS-CoV-2, which generates overlapping PCR amplicons. And you use that PCR pool to amplify the genome of the virus, and then you sequence them. So these are the two technologies which were used for sequencing the virus genome. After the genome sequencing is done, what you do is basically you have to take the raw reads out of the instruments and then you have to do the quality filtering. So usually we use forensic light and you filter out the low quality sequences out of it. And then we do the reference based mapping of the raw reads using Wuhan 1 as a reference strain. And then the variants are called and the annotation is being done. Another is, of course, there is a tool in Iron Torrent server which does reference-based mapping of the raw read. And again, they do the variant calling and SNP finding on that. Now, these two independently prepared genomes are compared, or which are done on two different platforms. And based on that comparison, the consensus of a virus genome has been constructed. You would wonder that SARS-CoV-2 is one of the very high sequenced pathogen in the history of mankind. And if you would look at the GuySed data, which is initially designed for an avian influenza sequence gathering, but since this is also a nearby virus, globally, the data of the SARS-CoV-2 sequences are being submitted on the GuySed platform. And as you can see that on 21st December, the first SARS-CoV-2 genome was uploaded on GuySed. And from there, if you look at, this is up to the 19th October, as latest as that, more than 151K genomes have been submitted. So typically that means around 522 genomes per day. Globally, people are sequencing SARS-CoV-2 genomes and submitting it on GuySed. These genomes are also available for students and researchers like you to download and do the analysis if you are interested to do some analysis on this. Now, if you look at these 151K genomes which are submitted there, they are divided into different clades. And these clades are basically, so initially when the pandemic started, there was only the first split that was into S and L region. That is, we used to call it S strain and L strain. Then L further evolved into V and G. And later on, G evolved into GH and GR. So if you are currently looking at, the global sequence data, this is the GR clade, which is the most prominent clade across globe as far as we are talking about SARS-CoV-2. Then this is GH, then S, and then V, L, G, and this is some of the other sequences. Also, we are using the different, so I had already talked about different mutations conferring to different strains or the clades. So here S is particularly the mutation of C2T at the position of 8782. Also at 288144 position, and NS8 to 84. So these are the changes which make a strain as an L. And then likewise, there are mutations for L, V, G, GH, and GR. They have been defined. So again, these are further based on their evolutionary time history. They are divided into different lineages as per the classification given by Pangolin. And this classification is A, which is corresponding to S, then B is L, B2 is actually V strain, B1 is G, and B1.1 is GR, and then GH. So this is what is the lineage and clade as far as the SARS-CoV-2 is concerned. Now, if we are talking about that, there are some ancestral lineages, which is basically the sequences which were originated from China, and from China where it initially started spreading into, say, Southeast Asia, Japan, South Korea, Australia, USA, and Europe. A1 is basically a North American lineage which originally came from Australia. A1.1 is from Ireland, and A1.2 is again, USA, Australia, and Canada. So likewise, the ancestral lineage of SARS-CoV-2 is also defined. So with the effort of the team at GBRC and our very learned director, Professor Chaitanya Joshi, when we had a meeting with Honorable Chief Minister, and we started the activity in the COVID genomics on 16th of April 2020, we were the first state government lab to sequence the first whole genome of a SARS-CoV-2 from an infected patient from Gujarat, and this was released by GBRC. Since then, we also developed an online platform which every one of you can go through and learn about it. It is covid.gbrc.org.in. And on that, from the first day to till date, whatever genomic work on SARS-CoV-2 in GBRC has been done is available for your understanding. So worldwide, as I told you, that B1 is the highest number of the lineage which is present on GISAID. And if you are looking at the clade distribution, the highest distributed clade across the globe is GR, followed by G and GH. And whereas, the L and others, they are very negligibly present currently in the global SARS-CoV-2 genomes. This is the data I've taken from nextstrain.org. This is basically a live genomics epidemiology tracking website, which uses genomics as an information. So Nextstrain derives data from GISAID, and then it is distributing it. So if you're looking at, almost from January 2020 to till date, this is how different phylogeny they have distributed. And the mutation that is estimated per year, according to this genomic information, is currently 31.4 nucleotides per year. Now, when we are defining the next strain has a different clade definition, and basically they have gone by the year. So in 2019, A and B is basically the root clade of the Wuhan China strain is 19A and their derivatives, and then 19B. And from 2020, whatever genomes have been sequenced, and the mutations are also defined over here, that is classified into A, B, and C. Coming back to India, In India, so far we have 2000 plus SARS-CoV-2 genomes sequenced from across different states. And here, as you can see, whatever the yellow dots are, those dots are attributed by Gujarat. So which is currently very high in highest, particularly in India. If you are looking at the mutation profile, then these bars, they represent the highest variable regions which are observed currently in India. This is the data taken from a platform called as GEAR, which is developed by CCMB. Again, if you are looking at the sample distribution, this is Gujarat, Maharashtra, and Tamil Nadu, which is constituting, Telangana, which is constituting more than 50% of the genomic resources of SARS-CoV-2 submitted from India. And this is the definition where, it is distributed over the age and male and female, as well as some of the unknown genders. If we are talking about lineages in India, then B1.132 has the highest prevalence. So overall B1 and B6, they are predominant in India. If you are looking at the clade-wise distribution, which is as per the next strain, this is how over a period of time in different states, as you can see, the clades of virus, they have changed. So currently A2A clade is the most promising or most progressing clade as far as it is concerned in India. So if we are talking about the status of the SARS-CoV-2 genomes submitted by different laboratories in India, this is the data on 22nd October. And as you can see that as GBRC, we have submitted more than 622 genomes on GuySed, and they are available on a public domain, followed by CCMB around 536, and then in IBMG around 403. So as a state government laboratory, this is the highest number of genomes which have been submitted by any institute in the Indian SARS-CoV-2 genome. For this, as a team, we have also wrote a paper, which is also available on the portal that I mentioned, and it is currently under revision in Frontiers in Genetics. Basically, I had already told you about the different GuySed clades and pangolin lineages and their defining mutations in the genome. What we observed, so this paper is the analysis of 560 different SARS-CoV-2 isolates, which have been isolated and identified with different. These are the mutations which were observed on a very high scale. And when we are talking here, the orange color identifies the missense mutation. That means it leads to a change in the protein and probably the function of that particular strain. With the help of this, you can also track that how the SARS-CoV-2 transmission took place in Gujarat. So this is how, as you can see over a map, there is this Ahmedabad cluster, and whatever, the lines that they are going from, say, Ahmedabad to Surat, those are basically the events which resulted into the spread of that particular virus. And as you can see that from Surat also, it has spreaded to the southern Saurashtra part and some of the other places like Rajkot and Jamnagar. So basically, with this information, you can understand how the genome sequence can help you to see the transmission. This is the phylogenetic analysis of all the sequences of the Gujarat SARS-CoV-2 and its distribution into lineages and clade. So as you can see that in Gujarat, we have B113 as the highest number of lineage present. And GH is the clade which is predominant in Gujarat, unlike the global scenario where GR is the highest. You can see that there are only 11 of the sequences belonging to GR clade in Gujarat. Now, if we are talking about this specific case where this particular mutation 28854 is predominant in Gujarat, and it's not that so frequent in other national and international sequences. This is what is the distribution across Gujarat, as you can see from the analysis. So the yellow one is the mutant over there. Then what we did here is that we wanted to understand the importance of these variants with reference to their association, whether these mutations are attributing to the clinical outcome of the patient or not. So basically what we did is we compiled a global database from the GuySaid for the patients which were given the clinical output, whether they recovered or they died out of that particular mutation. And similar data set has been gathered from Indian and the Gujarat based database. And as you can see that there are 200 variants that we found out which were common in that. And from the diseased and recover, as you can see that what is the trend that you can observe across different places. If you are doing a global Indian and Gujarat based analysis, this is a Venn diagram showing that how many variants are common in each clades in the recovered patient and in death. So we were trying to do the association mapping. This is again the diversity of the SARS-CoV-2 genome as represented by a different platform. So this is a UK-based platform which does tracking of the disease. And this is the distribution of D2G at 614 position haplotype, because this was the most dominant mutation which was observed in Wuhan at that particular time in China. And there are still controversies ongoing in scientific community about presence of this particular mutation with the final outcome of the patient. This is the novel coronavirus epidemiology in Gujarat. And as you can see that we have taken samples from almost every district and every part of the Gujarat based on the case incidence rate. And then we have sequenced these genomes and tried to show how these genomes are present in different population. So this is a hardcore genomics work, but if you have to use this genomic information in doing the predictions, then how you can do, I would run through a couple of examples. This was one of the very first paper published by Dr. Upasana Roy and her group based on the genome sequence of the GBRC at that time. So basically at that time, what they've observed is a particular mutation that is Q2R at the position 271, and as well as this mutation at 614D2G. So basically in this, they found out that the death rate at that particular time was high in Gujarat, and these mutations. So this particular mutation is basically lead to a better binding to the host cell receptor using the bioinformatics they worked out, and that is how it indicated increased virulence. Wherein the B has the reduced binding host receptor and hence the reduced virulence, which has helped in escaping the immune system and better adaptation in the new environment and eventual generation of the antibody escape mutants. So this is the very first hypothesis which was proven, where, still we know that in so many cases, the antibody response is not observed in patients who even after contracting SARS-CoV-2 mutation do not develop. There are other hypotheses also, because the patient had a low virus load which couldn't trigger the sufficient immune response to develop antibodies. But these are some of the other probabilities where scientifically we are trying to understand. Initially in my talk, if you remember, we had talked about R naught. So, or basically the effective reproduction number across time. So this is the data set where this data was again done on the Gujarat data set by David Jorgensen from the Imperial College London. And using at that particular time around 55 genome sequences were available. And what they found out that if you would see these dotted lines are the time when we had lockdown imposed across India. And if you would see that the R naught has over a period reduced from almost 2 to 1.55. And this is a very clear example that using the genomics information you are able to predict that how the disease epidemiology is progressing in a particular place. This is another paper which was published in Nature, and basically this ACE2 receptor, everybody knows that the novel coronavirus spike protein is interacting with the angiostatin receptor, which is present in our upper respiratory tract. And there are certain specific mutations, and those mutations have shown the really less binding efficiency of the spike protein. And that is where the host genotype comes into the picture. We till date also see so many asymptomatic COVID positive patients. So of course, due to their immunity, but also for their genetic mutations where they are less susceptible to such diseases. So there are a lot of mathematical models where we are trying to understand using the genomics as well as the epidemic information that how the transmission of the SARS-CoV-2 is taking place across globe, and what are the factors that will influence even the post-pandemic transmission of the SARS-CoV-2. So basically how is going to be the immunity. So if we would have the short-lived immunity, how the disease would resurface, and the incidence over time when we have the longer immunity, then the waves would be coming at a later stage, whether it would have seasonability or not. So without season and in the winter, how transmission will take place. Also with intervention, that is vaccination, and without intervention, how the disease transmission will take place. So these are some of the examples that we will have to help find when we are talking about the use of genomics and other things. Again, you have a very strong mathematical models which are predicted, which shows that how the disease is going to progress, and when it would come down. So this is a very interesting case wherein using genomics, the group in USA which has published the paper in Science, they have shown that how SARS-CoV-2 entered into the Washington state. So these are some of the examples that I'm trying to show, and look at the overall scenario of how the disease is progressing. So when we are talking about, say, the SARS-CoV-2 survival in the environment, there are very different hypotheses that are coming up on the air. I would also like to share one thing that we are additionally doing in GBRC is that using even the wastewater, we are trying to track the SARS-CoV-2 RNA from the wastewater and try to develop it as a tool for understanding the wastewater based epidemiology in the Gujarat state. Because, in a country like India, where we have such a huge population, you can't keep on testing people at a very large scale in the society But we know that how the excretion of the virus takes place when a person is infected, and that mostly results into the sewery lines of the city, which ultimately gets culminated into the wastewater treatment plants. And by studying the temporal changes of the SARS-CoV-2 genetic material at a different location from a different time point, we can predict how many number of the probable people would be infected, which are the area where the cases are increasing. So that is what will help in deciding the strategies of the pandemic progression in times to come. This is technically done on a very lighter note, and I had received it from some of the friends, where we can see that this is the weight of a virus, which is around 0.85 attograms, and it's actually about a millionth of a trillion gram. And if you want to fall sick, or if a virus wants to infect somebody, you nearly need 70 billion viruses. So that means it becomes around 0.0000005 grams. And then you are talking about, say, 6.9 million cases globally. So the total weight of the virus, that would come down only to 3.5 grams. And we can see that what 3.5 grams has done to the mankind. And also there are other sides of the stories where we have understood very important lessons in our life in this pandemic. The humanity has understood that how we need to increase our balance with the rest of the living beings on the earth is to maintain the harmony in order. So I would at the end like to acknowledge the dedicated team of GBRC who tirelessly worked during the lockdown, during day and night, for the various activities that were undertaken in GBRC as far as the COVID genomics is concerned. Our mentor, Professor Chaitanya Joshi, who has tremendous knowledge in genomics and genomic analysis. And of course, to the Kadi Sarva Vishwa Vidyalaya for giving me an opportunity to present this work. I'm sure I have not taken more time than it was allotted to me. We can take some of the questions if there are.
Thank you, madam. There are some questions from the students as well as faculty.
Yeah.
One student has asked, that is Harvey Vadir. He has asked that can a decreased infection rate of COVID-19 increases the chance of its prolonged existence?
Hello.
Can you hear me?
Yeah,
yes, sir. Yes, madam. Yes.
Yeah. So of course, the decreased transmission, the decreased mutation rate actually results into, so initially in my talk only I mentioned that when you're talking about a pathogen, a smart pathogen is the one that it doesn't harm a host that much, and that is how it also survives for a very prolonged period of time. One of the best example for mankind here is the malaria parasite. If you would know that for the generations they have survived or coexisted with the mankind.
Thank you, ma'am. Another question is, it is stated that coronavirus frequently undergoes mutations. Will it affect the detection of virus?
So basically, I had also mentioned in the beginning, that when we are talking about virus, see, there are billions of copy being produced, and a single point of change doesn't considered as a mutation. Basically, currently there are only this 5 to 6 clades which I defined, and a specific mutations where we can call it as a different virus strain. Coming back to the detection point, of course, if your RT-PCR primers they have different kids are using different regions for detection, and if your primer is falling into that mutation zone, then it can affect the detection part of it. But usually whatever kids are making this detection, they are looking at the mutations available at different location. Also on the guy side, you can see the presence of mutations and their frequency across genome, so that you can find out those regions which are not particularly that fast mutating in the genome and use them as a detection point.
Madam, another question is from Dr. Srikalp Deshpande, sir. He is asking genetic mutation and clinical output as recovery in Gujarat. Request to explain brief again. Can present treatment make difference?
Can you please repeat? Can you please repeat?
Genetic mutation and clinical output as recovery in Gujarat. Request to explain brief again. He is requesting you to repeat that genetic mutation and clinical output in Gujarat.
So basically what we have done in that paper is we have tried association of certain missense mutations with reference to the final outcome of the patient, whether the patient has recovered or died. And based on these numbers from the global Indian and Gujarat database, we have applied some of the statistical method. And based on that, some mutations, which is 28814 and 25563, they have been associated with the final patient outcomes. And the same work we have also reported in the variant analysis that I mentioned, which is also available for the detailed, look by those who are interested.
Next question is from a student, Pratyusha. She is asking, has there been any study about the mutation rate? As in, how long does it take for it to mutate, and what possible consequences it can have on severity of the disease?
Somehow the voice is getting interrupted. Maybe must be some issues.
Sorry, madam, I'm audible?
Yeah, please.
Yeah. Once again, I'll repeat the question. Has there been any study about the mutation rate? As in, how long does it take for it to mutate, and what possible consequences it can have on severity of the disease? Can we hope for a mutation that can weaken its virulence based on related viruses?
So basically, when we are talking about a rate of mutation, if you would remember, there was one slide which I shared, which is taken from the next strain. And according to that, currently, the rate of mutation of this virus is around 30 nucleotide changes in a year. So now you can assume that there are 30,000 base pairs. And in a year, it would lead to change of 30 nucleotides. And that is again in randomized process. So of course, we can hope for a mutation that can weaken the virulence because as the virus has to survive, also the human beings have to survive, right? And that is why we are putting in as a humankind a lot of efforts to control this virus. There is one specific mutation at a UTR region, which is in the transcription factor. And that is at a position 241, which is also very predominant in global genome sequences. And that has, shown initial results in weakening the transcription factors in SARS-CoV.
Another comment from student. Thank you, ma'am, for taking us into the genome of COVID-19. It now gives us a better understanding of the virus, and congratulations on the achievement of GPRC in decoding the COVID-19. That is
Thank you.
Student.
Thank you.
Now last.
Thank you, madam. Thank you for sparing your valuable time in educating all of us on genomics of COVID-19. And we thank you very much for sparing your time.
No, I actually, in fact, thank you and Gujcost for giving me the opportunity to present our work, and to all the audience for being so patient throughout the talk. So thank you once again.
Thank you, ma'am. Now I request Dr. Lakshmi to introduce the next speaker, Dr. Dilip Zaveri.
Thank you, sir. Next speaker is Dr. Dilip Zaveri. He has an experience of more than 30 years in microbiology. His PhD in microbiology. He's a consultant medical microbiologist, and he has worked for Novartis Vaccines and Diagnostics USA as a consultant scientific affairs from May 2008 to June 10, 2010. And he is affiliated to many organizations. He is a life member of Indian Association of Medical Microbiologists, Hospital Infection Society India, National Center for Quality Management, Indian Association of Sexually Transmitted Disease and AIDS, Association of Chemical Technologists India. He is also a member of American Society of Microbiologists, member of Indian Science Congress, and he has published around 17 international public. He has a credit of 17 international publications and 19 independent research treaties. Of this, 17 are national and 2 are international. It's my pleasure to welcome Dr. Dilip Zaveri to deliver the lecture. Over to Dr. Dilip Zaveri. Can you hear me, sir? You are there, sir? Oh. Sir, it is not audible now. Please unmute, sir. So it's not audible now. The screen is not visible now. Hello.
अरे अनाउंसमेंट तो करो.
To all participants, there is some technical problem. So meanwhile, we'll see some videos of Gujcost, posters of Gujcost regarding this coronavirus. After that, we'll join Dr. Dilip Zaveri's lecture. Thank you.
मैडम अभी ये मेरा वाला जो है ना कंप्यूटर, उसको आप होस्ट बना दीजिए. हाँ
Hello.
हेलो
Hello.
ये मेरा स्क्रीन चालू हो गया है। आवाज आ रहा है?
Hello. Dear all, sorry and apologies for initial technical problems. I hope, can you hear me? Hello. Am I audible to all?
Yeah, yes, you can start, sir.
Yeah, thank you very much, Dr. Lakshmi. Thank you. Apologies to all because of a technical problem with the laptop. I have been busy with changing it. So thank you for your patience. First of all, I would like to thank Dr. Sasikant, Dr. Lakshmi, and Team Biotech Department at Kadi Sarva Vidyalay, Gujcost, and Department of Science and Technology. And my special thanks to all attendees participating this webinar. This is a new era for all of us to face with COVID-19 pandemic. The global scientific community has responded well to the COVID-19 challenges in a very short span of time. From understanding its etiology to pathogenesis, diagnosis, and treatment. We have listened to speakers before me. They both have very nicely covered the clinical side of the COVID-19 as well as the genomic role played by gene sequencing by Dr. Joshi. So my talk will be around the laboratory and the major challenges faced by the laboratory people. The initial major challenges against what were like clinicians, radiologists, and microbiologists had a challenge in confirming diagnosis of COVID disease. Now we know the etiology. Now we know very well about the modes of transmission. We know how to control the pandemic and the transmission. More details are also being said that it is a droplet which are inhaled by people surrounding the patients, and if that is being inhaled, people are getting infections. So identifying clusters, containment, target treatment for antiviral agent, and prevention. These were the challenges against the still some of them like antiviral specific agent, vaccine is under development, and government also having lots of challenges. We're having still continued challenges are there like facility for the diagnosis, quarantine, treatment of active cases, and containing the infection. Initial challenges with the physicians and laboratories were like indications for the testing, when PCR, when antibody test, when antigen. In initial phase of this pandemic, there were only PCR tests available, but recently antibodies and antigen also being added before 2-3 months. And these are the tests used for different purposes. In case of disease like COVID, there are similar kind of symptoms and signs presented by various other diseases also. So for the physician, for differential diagnosis of COVID-19 and other diseases is very important. Appropriate sample, biological sample of interest, where now it is considered nasopharyngeal swab, oropharyngeal swab, sputum, blood, and stool. Stool is rare, only one case is reported by people, but nasopharyngeal and oropharyngeal swabs are used mostly for the diagnosis of this disease. Sputum and other lower respiratory tract specimens are being used when patients are seriously ill and admitted to the hospitals and other places. The sampling time also is important, which I am going to discuss. Clinical and immunodiagnostic requirements and its sampling. The challenges lies with the assays also itself. Test itself has its own limitations for diagnosis. So these are the major challenges for the laboratories across the globe. Now, with the kind of testing, the initial guideline, particularly for routine surveillance, which is published by ICMR, and containment zones, it is PCR or TrueNet or CBNet. These are the three molecular tests being advised by the ICMR for particular zone. In case of all symptomatic individuals with history of international travel, contact persons like laboratories, those contacts, healthcare workers and frontline workers are those who are involved in diagnosis and in contact with the treating the patients, and other returnees and migrants within 7 days of illness from other states. So these are the initial tests where RT-PCR is advised. In routine surveillance in containment zones with screening at a point of entry, like from other states to other cities to the migrating to next city, there the rapid antigen test is now advised, which is also known as RAT test, and RT-PCR for confirmation. So all symptomatic cases, including healthcare workers and frontline workers, all symptomatic direct and high risk contact in family, workplaces, elderly more than 65% of 65 years of age, immunocompromised patients, and those are having other diseases, that is comorbidities like diabetes and hypertension. So laboratory confirmed cases to be tested once between 5 and 10th day of the coming into the contact. All symptomatic high risk individuals, elderly patients, those with comorbidities in containment zones. So rate for containment zone, ideally it is suggested that 100% people living in particular containment cluster or zone should be tested by rate, particularly in cities where there has been a widespread transmission of infection. The other conditions, like in hospital settings, the choice of test is RT-PCR first and then rapid antigen. So all patients having SARI, that is severe acute respiratory infections of any other kind, to differentially diagnose them, it is required. All symptomatic patients presenting in a healthcare setting, asymptomatic high-risk patients who are hospitalized or seeking immediate hospitalization, such as immunocompromised individuals, patients with chronic comorbidities, asymptomatic patients undergoing surgical or non-surgical invasive procedures, not to be tested more than once a week during hospital stay, and all pregnant women near labor who are hospitalized in delivery. So these are the ICMR guidelines given for the choosing the test and for which kind of patients we need to test them. So testing on demand, this is a state government to decide, and to simplify the modalities, anyone can go to private lab or government lab and they can ask for the test PCR. So all individuals undertaking travel to countries, Indian states, mandating negative COVID-19 test at point of entry. That is, anybody who is traveling from other countries and arriving at Ahmedabad airport, he should also show the test report, which should be a negative. All individuals who wish to get themselves tested, tracking and contact tracing mechanism should be ensured by the testing laboratories by notifying, and all the laboratories, private and government laboratories, has to notify government health authorities for the positive test. The other points which ICMR guideline says is no emergency procedure should be delayed for the last lack of test. However, sample can be sent meanwhile for testing and indicated above. Pregnant women should not be referred for a lack of testing facility. All mothers who test positive for COVID-19 should be advised to wear a mask and undertake frequent hand washing while handling their baby for 14 days. They should not be advised on breast cleaning before feeding the neonates. These measures are likely to reduce transmission of COVID-19. All symptomatic neonates presenting with acute respiratory or sepsis-like illness should be tested. Patients presenting with atypical manifestations, stroke, encephalitis, hemoptysis, pulmonary embolism, acute coronary symptoms and other such should be also tested for this. Now the sampling time and type of samples, which is very important factor, and because of this most of the time test comes negative if it is wrongly collected. So the right sample at the right time is important for diagnosis. So coming to this is the period, the light blue color to light blue again. In between there is so this is the symptomatic period wherever the person is getting or contracting virus. The 5 days incubation period, 0 to 5 days is an incubation period where it is a window period. Then the symptomatic presentation starts. At that time, the viral RNA is available for collection. So virus can be detected in early and late phase. Virus is having window period where viral copies are less or viral load is less. So, and from the 5th day to 10th day, or you can say 15th day, 14th to 15th day is a mean time observed by various people, and from there the IgM start rising, and then the IgG is rising. How long it is not being known to anyone right now, but it is seen with the positive cases. So after virus can be detected from 0 day till 28 days, reported by some studies, IgM remains positive from 7th onwards to 21 days, and IgG can be detected from average 14th day onwards. So this is the normal sampling time for each case, and this is explaining about the windows. Now the sample, which sample is important and how it is to be collected and transported. Patients, those who are having symptomatic presentation, NAT, nucleic acid amplification test is advised. For that, the lower respiratory tract specimens are sputum, aspirate and lavages. Most of the time, aspirates and lavages collection is dangerous for person who is involved in it. Sputum is more easy to get and can be collected in a sterile container and can be repeated also anytime. While for initial screening, upper respiratory tract specimens like nasopharyngeal and oropharyngeal swabs are appropriate. Nasopharyngeal was and nasopharyngeal aspirates are also considered in certain situations. Considering stool, whole blood, urine is mostly very rare in diagnosis of COVID-19, but for studies where the spreading of virus can be studied in various samples, and that's why this has been reported by various workers. And many tissues like lung tissues from autopsy also helps to understand the pathogenesis of the disease. Patients for serology, when antibodies to be tested, the serum is important, and serum is to be sampled and can be transported. Whole blood can be taken in a plain vial and can be transported to the laboratory. For context, nasopharyngeal and oropharyngeal swabs are enough for antigen testing, and serum also is tested for certain surveillances. Now the specimen types and how to transport them. Nasopharyngeal swabs can be kept 2 to 8 till 5 days, and for further you want to keep it for further testing or research, it can be reserved into dry ice or -70 refrigerator. So most of the specimens are stored in -70 and below 2 to 8 for normal routine day-to-day practices. Now what we do with the specimens and how we detect the COVID-19 virus. So as a whole, we know that we understand that the virus is having a specific structure with membrane glycoprotein, nucleocapsids, spike proteins, and envelope proteins and internal RNA. These are the proteins available for diagnosis. So RNA can be detected in a molecular testing, and COVID-19 viral antigens from particularly envelope virus and nucleocapsid protein are very easy to, it's not that easy, but can be tested in a test showing antigen testing. Whereas in antibody, IgG and IgM is well known for testing, and these are the tests where polyclonal and monoclonal antibodies now it is prepared by some of the companies and available for use. So, as a whole, in any diagnosis, we use different types of modalities for laboratory testing. So, similarly for COVID diagnosis also, there are different modalities available for kind of a testing. Here, the methods are like viral culture, viral sequencing, antigen antibody detection, nucleic acid amplification testing, and CRISPR-based assays. Coming to the viral culture, this method is not recommended for routine laboratory practices as it requires specific facilities like BSL-3 laboratory, needs trained staff, expensive, whereas it can definitely help us in research to study the properties of virus to develop vaccine. The next is the electron microscopic view of virus. The viral gene sequencing, which is very well made, understood by Dr. Joshi. It is also a method where virus can be detected, but the virus, similarly, the method is complicated as well as it requires specialized facilities, expensive equipment and reagents. You need trained staff to analyze the data and cannot be practiced in a routine pathology laboratory. Whereas it can help in research, as Madam said, it can be helpful in confirming the presence of virus. It can monitor viral genome mutations and helps in understanding epidemiological and pandemic aspects and progression of the disease. So this is a very good method but cannot be practiced in the laboratory. Antibody testing is not used for diagnosis of COVID-19 and it is based on IgM, IgG antibodies, and they are these antibodies are response to the viral antigen, and still we are very premature in understanding the immune response given by the human system at various places, particularly in different geographical areas, and hence studies are coming up with more detailed information, and specifically when there is the virus is belonging to the corona family, where other cold causing diseases, viruses are also having similar proteins which can cross react with these proteins and can give you a false positive responses also. So that is being a very challenging part of the developing the test as well. But commonly this is the method how you can test for antibody. If there is a three line, that means control, IgG and IgM, both the responses are there. If there is a G, you can interpret that this is a past infection, and if it is IgM, it is early stage of infection. This is very common with each and every pathogen. So in antigen testing, we have proteins like spike proteins, glycoprotein, nucleocapsid protein, membrane glycoprotein, and small molecular proteins. Whereas normally S and N proteins are being used for antigen testing in commonly prepared kits and available market kits. Antigen detection as the viral titer in sera and nasal swabs, the antigen detection is more difficult as compared to antibody as of it now. Many companies have released ELISA kits for the detection of SARS-CoV-2 and with N and S proteins. Several monoclonal antibodies are also developed by companies for clinical testing of antigen detection and received promising results in early days. So this is the normal corona entry and exit of virus from human cell. This is the response which I think everybody has explained, but from asymptomatic phase, 0 to 5 to 7 days, symptomatic phase comes, and then the decline of viral load is very common with this, and this is the only thing which is giving us false negative in particular cases. In rat testing, Government of India, ICMR, has given particular guideline and algorithm where rapid antigen test is positive, then and irrespective of symptomatic, he should be reported as a positive. In case of negative, you have to see symptomatic. If symptomatic, go for RT-PCR, and if asymptomatic, then test them again if symptoms are appearing or he becomes symptomatic by RT-PCR. So all positive and negative results should be informed on the website, and it should be logged to the local data as well. Now the most widely accepted method, which is reverse transcriptase real-time PCR, which is currently widely used and accepted as a confirmatory diagnosis of COVID-19. Molecular tests have generally targeted a combination of following genes: envelope gene, RNA-dependent RNA polymerase, nucleocapsid, and open rate frame lab, ORF1A and B. So these are the 4 genes which are being targeted by various kits, or combination of genes are being targeted by various kits. WHO has recommended E gene, RDRP gene, and N gene for first line of screening and confirmatory testing. CDC is referring N1, N2 gene, and RNS and P gene, which is in a control assay they recommend. The procedure of RT-PCR is getting your nasopharyngeal swabs. From that, the swab is kept into the virus transport medium. Then RNA is being extracted, and with the help of reverse transcription or use of using reverse transcriptase, it is being translated to copy DNA, and this copy DNA is amplified and detected in your thermal cycler. So this is how the normal PCR as well as real-time PCR works, and the similar methodology is being used here. But the steps involved includes like nasopharyngeal swab. If patient is not informed before inserting that this will happen and swab I will be rotating for 10 times this or 10 seconds like this or that, then the patient becomes apprehensive and sometimes you do not get the right specimen. Swab should enter to the nasopharyngeal area, and swab should be rotated nicely. Then you get the ample amount of material for the testing. So these are the various stages where you can say it is a kind of a pre-test, during test, as well as post-test. I'm going to discuss about the same next. So as it is said, CT value. The CT value is simply a threshold where the viral copies are being detected. So if it is low, that means the viral load is very high, because in a cycle of test, in an early stage, that is 1 or 2 or 10 cycles, it comes positive. That means you have got a high viral load. And where there is a higher CT value, more than 39 or 40, average 40 is considered. From 25 up, it becomes little doubtful kind of a thing, and then above 40 is negative. So this is how the CT value is being interpreted. And in initial stages of the disease, there were only qualitative tests were reported. No quantification has been done, but now manually quantification is being done by various laboratories, as well as the facilities with quantification of kits are available. So CT value is as well important while interpretation of the test. The government, particularly our Indian Council of Medical Research, which is coordinating and this particular pandemic, and their responsibility is lying with the pandemic, and hence they time to time declare various guidelines. Similarly, they have declared which test is to be used, which tests are being validated in their laboratory, which tests are being approved by FDA, and which kits are to be used. So in first line screening, they have approved e-gene assays, which is being uploaded by them, and anyone can see there on the site. CDC has also given a test interpretation guideline where N1, N2 genes are detected. If all 3 and RDRP gene is absent or positive, then it can be considered as a positive for COVID-19. If any of one gene, N1, N2 is being detected and RDRP is negative, then it is an inconclusive report result, and you have to retest after resampling. Then if both N1 and N2 is negative and RDRP is positive, cannot 2019 novel coronavirus is not detected, and you have to report it negative only. In all three negative gene or absence of gene, you have to consider invalid result, and you have to retest and repeat the extraction. WHO has also similarly given a guideline for a screening test, confirmatory test. When screening and confirmatory both of tests are positive, we have to consider COVID-19 positive. Screening test is positive and confirmatory test is negative, then you need to say it is not COVID. Screening test negative, confirmatory test negative. Obviously, SARS-CoV is not detected, and screen test negative and confirmatory test positive. You have to refer this to reference laboratory for additional testing. So these are the criteria explained by the WHO for any laboratory test which we are using in the laboratory for COVID-19. For how many times one has to be tested, the frequency of testing. A single RT-PCR or TrueNet or CBNet or RET positive test is to be considered confirmatory without any repeat testing. No retesting is recommended prior to discharge from COVID-19 facility after clinical recovery. These are all guidelines given by the ICMR. If symptoms develop following a negative RET test, repeat RT-PCR test or RET is advised. So these are the guidelines given by ICMR for any kind of testing. Now, to sum up with all this, we need to understand the challenging in testing. Challenges which we faced in testing are pre-analytical, where sampling and time of sample collection, this to be strengthened. Transportation is very important. If pool chain is not maintained, you may lose RNA because RNA is very sensitive. Then the DNA can be transported in any odd conditions, but RNA is normally decay. So during analysis, your extraction method is important, extraction reagents are important, amplification is important, amplification cycles are important, and detection method is also important. Post-analysis interpretation is also important, kind of a CT values and others. So these are the challenges in testing. The important issues related to laboratory diagnosis of COVID-19 using various testing methods, we find false negative just because of detection of viral RNA or low viral RNA, or maybe sample is not collected properly. That becomes an issue with the false negative. Particularly viral load from contracting infection to onset and symptoms. You know that from the beginning of the 5th to 7 days to 28 days, viral load is good and we can detect. But in very mild cases, viral load can be low and there it can come negative as well. So the use of diagnostic methods, clinical, radiological and laboratory, combination of all three is required for any confirmation kind of things where the doubt is arising. The treatment of samples, we discussed the false positivity, mostly it can be with the antibodies as well as it can be with antigen sometimes, whereas false negativity can be also occurring with certain kind of immune responses to detect the antibodies. As Dr. Madhuri well said, that immune responses are different in different regions, and different proteins are also responded differently by people. Hence, more studies and research are required in this kind of a pandemic. The current challenges in research opportunities for researchers are like, collection of right sample, maybe more comfortable devices can be devised, or more simple methods can be used, and that those things are to be studied in detail with the presence of viruses. Particularly time and type of sample is also important to study in local areas. Storage and transportation studies are not seen by people, and it should be also studied very well, because most of the time from rural areas there is no RT-PCR facility. People are transporting samples to the cities or the center which are designated by government. So while transportation, I have seen when I was working with the HIV, where we studied and carried out more than 19 biological surveys. These were the major issues before 15, 20 years. And now it is being resolved by cool logistics and other things. But still in local areas where the remote village sample cannot be transported without, without the probabilities of, revival of the RNA. So these are the practical issues which we have to resolve for getting good test results. Amplification, detection, validation of results like sensitivity and specificity. These are the further areas where person can work with the smaller data also. But for local, I think will help other people also to understand the pandemic. Geographical strain variation, which lies with the mutation, Dr. Madhvi very well explained, but mutation is a major issue also. No doubt with RNA viruses, it is not much seen, but as virus has jumped from the other species to human being, and now from human to human transmission is taking place. In this scenario, it is always seen that the genes are mutated, and once we see some kind of a good mutation which will inactivate virus or it makes less virulent strain, which will help us to see in near future. Genetic predisposition, particularly human genetic factors, may contribute to the extreme high transmissibility of SARS-CoV-2. Why particular people are getting, why particular type of people are getting, these things are also to be studied very well so that it can give more insight to understand the pandemic and to consider the new strategies for controlling the pandemic. ICMR has given, this is just general information for the people, those who are attending, particularly for students. I would like to tell them that any kind of test or any kit which is being accepted on a national level, that time the coordinating agencies are validating the kits, and similarly ICMR has validated many kits. Also, they have given the criteria that if US FDA approved kits are there, then there is no need for validation. So these are the requirements for RT-PCR. Like it should give you 95 to 99%, 95% sensitivity and above, and specificity should be 99%. In most of the cases in PCR, the sensitivity which is being practically observed in the field is running between 30% to 90%. Many studies are being reported the sensitivity 30% only, whereas very well managed system where the transportation, collection, and everything is at place, they have reported more than 90% of the sensitivity. Specificity is most of the time 90%. Virus transport RNA extraction kits, for that also it is 95% concordance among the positive, means at least out of 100, 95 positive cases to be reported positive, and at least 90% concordance among the negative samples. That means if I test 100 negative samples, it should give 90% negative. So this is the concordance of the RNA extraction kits. Similarly, the VTM should preserve 100% RNA gene so that it can be transported very well. The antibody rapid testing kit sensitivity should be 90%, but it is reported by people like 70% to 90%. Even some cases, 50% only reported by the people. So, in case of ELISA or CLIA, which are more sensitive, should be giving 90% to 99%. So these are the different kind of acceptance criteria for validation as well as acceptance. Guidance on rapid antigen testing also, it is given by ICMR that sensitivity should be 50% and above. Specificity should be 95% and above. So these are the different validation criteria and guidance. Hello.
Participants, please mute yourself.
The validated and approved RAT red kits from ICMR is used in the field. Some of them are listed here: SD Biosensor, LabCare, Tribitron, Coris, and Panair. So there are so many kits approved also, and so many kits are rejected by the ICMR for testing. So this is how the uniform policies can help controlling pandemic. So different fronts of particular in case of pandemic, different fronts has to fight with the uh, type of problems, and this is how the laboratory has to fight with the pandemic, and laboratory has to prepare themselves for the situations which may come in future also. So I end my talk here, and I request participants to have any questions. I'm ready to take your questions.
Thank you, sir.
Hello.
Thank you, sir. And there is a question from Dr. Subodh. After how many days this virus has become ineffective?
See, various studies are reported. Normally ineffective in what sense? I would like to ask him similar further to clarify his question. In what sense he's asking me about inactivation of the virus?
Causing diseases.
In human being or in any other environment?
I think it is human being.
Yeah. So so you are asking about the infectivity, when the person's infectivity decreases. Actually, it is virus strain. Normally, when it goes down to the 100 copies of gene, that time you do not detect in RT-PCR, and we normally say it is 28 days, studied by various people, and 28 to 30 days it becomes less than 100 copies in a person. So that time it becomes, virus is not becoming inactive, but it is not detectable, and so the person becomes non-transmissible. So he is not transmitting the virus. See,
next question is how VTM kit work and explain briefly.
Yeah, VTM kit is having guanidine into it, which is preserving RNA to decay further, and it is helping us to preserve the RNA molecule into the VTM. So main component which is preserving virus gene into our VTM is guanidine, which is preserving the viral RNA.
Yes, sir. Dr. Maitri Severi want to ask you that whether the RT-PCR COVID testing is available at your place.
No, we are not doing.
Sir, I have a question, sir. Earlier, as the pandemic occurred, there was a suggestion that BCG vaccines can be given to the patients. How this BCG and corona is related? Whether is there any structural?
Again, there comes with the immune response. When BCG is given, suppose myself, I think I received a BCG, and after that I have been never tested for anti-tuberculous antibodies. Similarly, we don't know the reactivity and cross-reactivity of the particular proteins when it is being processed in our body. So it was probably people, they considered that African countries, India and other Asiatic countries are having low cases, and that's why this could be one of the reasons. But still, I have not gone through any study which has proved that BCG is preventing people.
Sir, another question is from Deshpande sir. Is it possible rapid test at two different places may show positive and other as negative if the sample collected the same day?
Yeah, it is possible. I think before few days only there was in a newspaper about one father and son. They both were tested at one place positive and then at other place it was negative. And that happens with us, as I told you, no, it is sampling which is important. If at one place it is seriously taken a sample which gives you a positive, then at other place just swab is inserted and removed and then taken it for the testing that gives you negative. So it happens. That is very common. We have observed during HIV also we have observed such things. So that is very common. So sampling is very important. If it is not collected nicely, you may not get proper material for testing.
Thank you, sir.
Welcome, sir. Thank you. Thank you. Thank
So
you very
thank you
much.
very much. We thank Dr. Dilip Zaveri for elaborating on the different tests that are available for detecting COVID infection and other related topics. Thank you, sir. Now I request Dr. Falguni Patel to give a brief introduction about the next speaker.
Good afternoon, everyone. On behalf of Department of Biotechnology and Microbiology, Shri Manikal M. Patel, Science and Research, Kadi Sir Hoshikar, it's my privilege to welcome Dr. Natuvali Jayachandran, a renowned Ayurveda Acharya from Ahmedabad city. Sir was in the panel, Ayurveda panel of physician, then Honorable Governor of Gujarat, Mr. Om Prakash Kohli. Right now, he is in the Ayurveda panel of physician to ONGC Ahmedabad. He is the advisor to Global Swasthya Kendra, United Arab Emirates. His specialty is in the treatment is in the diabetes, arthritis, infertility, Ayurveda, classical, Kerala, Panchkarma. He is received of many awards like National Mahadhanvantari Sampat Pushkar Award, Maharaja Swati Trinwal National Excellence Award awarded in Dubai, Maharaja Sri Charitra Trinwal Nyatya Kala Kendra Puraskar in Ayurveda, Pratiksha Trustee Excellence Award in Ayurveda, Sathigri Ayurveda Saman, Ayur Ratna Puraskar, Smriti, Samskriti Puraskar by Anandashram, Honorary Doctorate in Ayurveda provided by Sri Lankan government. He has published many papers in Ayurveda literature in many international and national seminars. He completed around 2,000 lectures in subject related with medicine, philosophy, literature, education, personality development, spirituality, peace, and reconciliation. It's our honor to have him as a speaker in our webinar. Thank you, sir, for accepting our invitation. Now over to you, sir.
Hello? Please unmute yourself. Hello? Not audible.
Now audible?
Yes, yes. You can start.
Okay. Okay. Thank you. See, well, good afternoon to all of you. I think all of my friends from Kadisarva Vishwavidyalaya and respective branches are in a very, very interesting and effervescing type of discussions in the deep-rooted system of medicine related with the new pandemic. So my view, because once I start the program, I'm the last speaker, so my duty is to give you more information in entertainment sections like that. Because the last speaker always wants to entertain the people, because it's so difficult at 12:55 speaking on corona. As per the Ayurvedic concept, is like a criminal offense, because this is a time of the full lunch time. I'm obstructing all of you and taking back into the Ayurveda perspectives. Anyway, I try myself best to entertain all of you through interesting aspect of how Ayurveda is perceiving and analyzing and seeing the pandemic. See, a few interesting aspects I'm trying to mention to you. Uh, See the first slide. The first case reported, I think a few of my fellow previous speakers maybe explained all these things. The first case reported in Wuhan city of Hubei, a province, Republic of China. And there is a confusion between 6/10 2019 to 11/12 2019. There was such incidents of these cases, means around October the chances that the corona infection started. And this, another debate and discussion is there till December 11. But confirmed case is reported on 31st December 2020. We are standing on 23/10/2020, October 23rd. That means we are celebrating a corona 297 days of celebration. That means 9 months, 23 days. So previously, it was basically a kind of interesting subject to all people. Initially, it is an amazing, then it became fear, then it became a panic, then it became a concern. Now, I think the world, the universe is discussing one name, that is Corona. Before 2019, 31st of December, Corona is the name epitaphed by a liquor. The liquor Corona into the pandemic Corona, then all the people are now envisaged, or they are highly concerned about this particular name. See, 297 days we are passing. The world, as per the world history of Corona, and we are passing 287 day after having the first death, which was reported on 11th January 2020. So when we consider the Indian scenario, the first case is reported in my hometown in Kerala, in Trichy Medical College. A girl who studied in Wuhan returned back to Kerala on 23rd of January. She was quite okay, and she was very energetic. She was a medical student at Wuhan, and 24, 25, 26, she was quietly normal, and 27, she started a little bit of irritation, sore throat, and mild fever. Then because of the more awareness, that time the awareness about the corona increased a little more, and immediately she reported into the Trichy Medical College, and the doctors and the government divisions immediately kept her in the isolation. Her sample tested from the first day, 7th day, 9th day, 14th day, 17th day. All these tests are positive, and on 19th day the test result was negative, because the sample, those days the frequency of the test and availability of the labs are not that much, so they collected the sample and sent into NIV Pune, and they got the information. On 19th day she was discharged. So the first case reported in Trichy in Kerala in Indian pandemic history was 27/1/2020. That means January 27. As on 23rd October, India is celebrating Corona 271st day. And the first death in India occurred in Karnataka. The place is called Kalburgi. A 69 of Corona in India that happened on 12th March 2020. So after the first death, as on 23rd, we are standing on 226th day. In Gujarat, the first report comes from Rajkot, simultaneously from Surat on March 19, 2020. From Surat and Rajkot simultaneously. As on 23rd, in Gujarat, we are celebrating 219th day. The first death reported in Gujarat, that is on January, 22nd 3, 2020, means on 22nd March, a 69-year-old person from Vadodara succumbed in front of the COVID pandemic. And now from that date onwards, on 23rd October, we are passing 216 days. Why explained these days? Because in the history of any diseases, except the Spanish flu and certain small level of the epidemic, such a huge days and huge level of an infection presence in the earth is not that much available. So these days had given lot of subjective information, pathetic information, panic, lot of problem to the human generations. And still after a 271 day, we are not anywhere in a preventive, absolutely away from the corona aspect. Still, people are infecting and infection is spreading, but variations are happening. Somewhere it is low, somewhere it is high. So this gives an abundant chance how we can able to move in future, what are the precautions we want to know, how we want to think about our health, how we want to think about our future programs, like the new normalcy of the post-COVID era. So a lot of scientific, social, political, and cultural aspect are providing to us, because the time corona moves away from the world, we are in a new format of life pattern. And that format is people are thinking about it, and at the same time we are not merging into that one, or we are not able to recognize it. And slowly sociologically, scientifically, we are planning to approach into that level. In that time, what kind of a traditional information, and what kind of our asset, the national asset of the medicine and the folklore thinking and folklore aspect can able to help the people. In that era, one of the world's most recognized and debated subject, that Ayurveda, which originated in India, and which has got Indian gene and Indian culture and Indian ethos, how it is implementing, or how it is transforming, or how it is contributing to a normal life, be it in the COVID time, or be it going to be in the pan-COVID time. So few informations or few idea regarding the Ayurveda I'm providing to you. And when I come to the last phase, especially the fellow students and the research scholars and academicians, what you can able to take it from Ayurveda for the future research perspective, that few points also I want to communicate with you. See, the traditional, even though if it is a traditional system, way back to BC, never feel that, those days we are not able to aware about the communicable disease. Yes, the first information regarding with the communicable diseases are provided by the Sushruta. According to Ayurveda, the communicable diseases are called Auvasargika Rogas. That is mentioned by Acharya Sushruta. What is Auvasargika Roga? Auvasargika Roga means that originate either from an animal or some sources, and it invade into the human system or any other allied creatures. So how it is affecting or how it is happening? Because the Auvasargika Rogas are classified in Ayurveda as per the skin diseases. Few skin diseases are communicable. The skin diseases is called Kushta. Kushta is not a leprosy. Kushta means the skin, that disease affecting on the skin is called Kushta. Skin diseases. And second is communicable fever, Jura. The terms in Sanskrit, Jura means that increases your body temperature as well as physical and mental effervescing changes felt in the body is called Jura. And the third one is emaciation, Shosham, means losing the body strength, even the quality and quantity of the body integral principles, integral materials are getting weak. That is called emaciation. And viral conjunctivitis. What viral conjunctivitis in Ayurveda we call is Paramanu Anu Netra Abhishinga. According to Ayurveda, the Anu is called bacterial and Paramanu is called viral. Viral conjunctivitis we call Paramanu Netra Abhishinga. The body's Nidana Parivarjana Ridi, elimination of etiological factors from the host, is the predominant aspect recognized and conferred by Auvasargika Rogas. I just mentioned about you the Abhishinda Juras. It's a communicable fever, is caused by Paramanu or virus. We can correlate like that. Due to why it is happening, why this Paramanu is making problem, the details are there, and it is due to a particular word is called Jana Pada Udvamsa, contaminating dwelling surroundings of human life. Jana Pada Udvamsa is the basic feature, basic problem by which the communicable or the Auvasargika Rogas are happening. See how this Jana Pada Udvamsa Rogas are happening. Just see the interesting aspect. Janapada Udvamsaka means a socio-preventive violation. What are the socio-preventive violation? Air is called Vayu, contaminating air intentionally. Water, contamination of water or jalam intentionally. Soil is called Desham, contaminating the sand and the land intentionally. Kalam. Kalam means the climate, contaminating the seasons. How the contamination is happening is called a prasanga. Prasanga in Sanskrit means mutual contact. And gatra samsparshanad, skin to skin touch. And nishwasad, exhalation of the air. Sahabhojanad, sharing the food, means if you provide food to somebody or collect the food from others, it's not that. In a time of infectious time, the sharing the food that is consumed by an infected person to another person, that is called sahabhojana. And sahashayana, and the living. Sahashayana is not merely sleeping with the infected person. If you are moving along with an infected person without a distance, that is called sahashayana. And asana, sitting close to each other, those who are having infective. And using vastras, the particular kind of the cloth which is used by the infective persons or the person in contact with the infected persons is sharing it, is also giving Janapada Udvamsa or called the infective conditions. And Malya and Anileba. Malya means, in Ayurveda is garland. Garland, no, it's not merely means of garland. That which you provide to somebody knowingly, unknowingly, or a gift or a material, anything that you provide as worthy thing to somebody, not in a consideration that the person has got infection. So the infection pass knowingly, sometimes unknowingly, from one person to another person. That is called malya or garland. Anulebanas, certain attires which we use ourselves. In that attires we will share with somebody, even again knowingly, unknowingly. That is also called Janapado Udhamsa. And another one, how this Janabada, what are the causes? How this Janabada Udhamsava converted into Aupasargika Rogas means the Janapada Udhamsaga, the destruction and eliminations of Janapada, how it creates Aupasargika Roga. See, Pratnabharada. Pratnabharada means intellectual error occurring knowingly. It's an intellectual error occurring knowingly, that is called Pratnabharada. What is the reason for what will contribute to this Pratnabharada? The Pratnabharada will contribute into adharma. Adharma is not a philosophical word. Adharma is a very technical, practical word we call the wrong actions. The intellectual, knowingly, the intellectual the idea or the information that we have, that we pass on to another section, and that creates a special action. That action is called adharma. This adharma, which is caused due to the Pratnabharada, will create Janapadodhamsaga, means the natural or habitat or the place where we are living or the place where other people has to live is getting contaminated. So the Janapada Udhamsaga create Aupasargika Roga called communicable disease. From the Aupasargika Roga, that getting into the two varieties, that is called Janamara, means in an area only the particular infection is starting. That is called epidemic or Maraga, very serious. It moves from one area to another area, and it will move to different locations, to different state, to different nation. That condition is called Maraga, or we call it is a pandemic. So we are the viruses we discuss, the SARS corona virus 2 that we are discussing, according to Ayurveda, it comes under the Maraga divisions or called pandemic. See, how infection and health is related as per Ayurveda. There are three important factors. One is called the kalam. Kalam means climate. Climate means seasons. Or artha. Artha means the sensual perceptions. Means you have a senses, 5 senses. The 5 senses are creating and coordinated impact with the society or impact with the nature. And the connection between your senses with the nature, which is not using or providing or working properly, that will create infection. Kala, I mentioned you previously, the season. We have 8 type of Kala, means climate: Grishma, Varsha, Sharat, Hemanda, and Vasanta. These are the six type of the Ridu we have. This Ridu is influencing our body system, our mind, our day-to-day cycle. Any aberration comes, any day-to-day activity that we have to do in a particular climate that we are not doing, or sometimes we will do it in exaggerated way, or we do it in a very misuse way, that will create infection. So kala, artha, and karma. Karma means the activity of your 5 senses. Like the eye is seeing, the nose is perceiving the smell, tongue is tasting, the skin is in tactile in condition. These 5 senses that doing a specific work is called karma or indriya karma. The activity or the conditions of indriya karma, the changes in the climate, and the way we are utilizing the 5 senses If we utilize, if we use it in over, that will create disease. If we misuse it, that also will create problem. Or we use it excessively, that also will create disease and infection. So the climate, the senses, and the activity of the five senses, what we have to do, we have to use it in a normal way. If we are not using in a normal way, that creates a disease or infection. If we use it in a misuse way, that also creates disease or infection. And if we use in a moderate way, as per the science says, as per the system says, as per the information gained by the recurrent research says, then we will have a very positivity. And see how before venturing into an infective conditions, whatever it be, whether it is a corona infection, whether it is a viral, bacterial, spirochetal, whatever it be, there is a particular changes is happening in the body. Or why these changes are happening in a human body? That is mentioned in Ayurveda. That mentioning particular thing is considered as the condition of health or condition of the surety of the health. Samadosha, samagnisha, samadadu malakriya, prasannatmanindriyamana, swasta midi abhidiyade. A very, very important. This is considered to be the definition of the Ayurveda health. Health is defined as a complete mental, physical, and spiritual well-being of a person, not merely absence of disease and deformity. Very important, not disease and deformity. If we are completely safe in our consideration physically, are we healthy? Or if we are comfortable with certain surroundings and certain situation, are we healthy? No. The health is depending upon your physique, your mind, and your spirit. Spirit not means spirituality. Spirit means the something that is effervescing, something inculcating from your body. That is maybe an innovative, that may be an indutional. The innovative inductions that is happening in your body also contributing to the health. Because this is a very important point that we are debating in the COVID time. In a containment time, in a lockdown time, what is happening? That the spirit plays a big role. You are physically okay, you are mentally okay, but you are not comfortable, occupied with, or talented with the spiritual aspect of the human system. You will not enjoy a sound health, you will have an attributed health. So we have to study, in a new generation has to know whether all the blood reports are normal, all the investigations are normal, all you are the physically, what are the criteria is mentioned as a healthy man, is you are representing, you are having the strong evidence of all these things. Are we healthy? No. That is an important thing, this particular shloka that is mentioned in Ayurveda. Samadosha. Samadosha means equilibrated body constituents. I'm talking about the constituents means not the legal constituents, not the philosophical constituents, not the political constituents. I'm talking about a body integral constituents. According to Ayurveda, the body integral constituents are three: Vada, Pitta, and Kapha. Vada, Pitta, Kapha is a postulate. No. What we perceive as a Vada, Pitta, and Kapha in our general information is not that. Vada means locomotion. Pitta means change, metabolism. Kapha means stability. The stability and stable functions that is happening in your body comes under Kapha. The changes that is happening in your body is called Pitta, and the movement that is happening in your body called Vada. So Samadosha, these three integral portion has to be normal. Samagni, what is Samagni? Samagni is the normal metabolic condition. Agni is not fire. Agni means change. According to Ayurveda, body is built up of the 7 dhadus: Rasa, Rekta, Mamsa, Meda, Asti, Majja, and Shukla, Sapta dhadu. From One dhatu, it converted into another dhatu, from the rasa to the rekta, rekta to the mamsa, mamsas to the medhas, medhas to asti, asti to shukra. And this conversion, this transformation needs an energy. Or our human body is also undergoing a lot of convertive procedures. All this conversion needs a kind of changing energy. That changing energy called Agni. The Agni has to be functioned properly. It's all metabolism, whether it is fat metabolism, carbohydrate metabolism, or the homeostasis that is happening in your human body needs upgradation and change. This upgradation and change is created by energy. What kind of energy? The replicating energy. So samagni means the normal metabolic conditions. Samadhadu, the equilibrated basic system of the human body. Like I told you previously, Saptadhadu, Rasa, Rekta, Mamsa, Meda, Asti, Majja, and Shukla. These are the body building conditions or body building integral part. All these dhadus has to be in a normal function. Your blood has to function properly. Rasa means that food that you are taking is converted and changed into the ultimate absorbing material. From there, it enters the body develops. The rasa is converted into rekta. It needs an energy. It needs an energy equations. So that from that particular 7 dhadus are called sapta dhadu. And the samadhadu, the function of the dhadus or the integral basic principles by which the body is built, that has to be in a normal position. Malakriya. Malakriya means the normal antioxidation scavenging activity or the waste. Waste means not, we are always waste means we always think about the gross waste, like the excreta. No, body has got a lot of waste because the body is undergoing all the time the oxidation. As per the oxidation, the creative or assimilative portions are also built up and the waste products also are coming. The removal of the waste product is an important thing. We are always thinking about the gross removal. What is the subtle removal? The subtle removal is an oxidative procedure. That subtle removes needs the oxidative waste which is accumulating in the human body has to be scavenged off. So the gross removal of the waste and subtle removal of the waste, both together, comes under the malakriya. That has to be functioned normally. Because as per the modern medicine, as per the modern thought of the medical information, most of the diseases are created because of the lack of antioxidant activity. The human body means the body is not perfectly cleansing it or removing the oxidative molecule which is accumulated in our human system. So that particular aspect, years back or from the first thought of the medical aspect comes, they mentioned. So samadosha, samagnishi, samadhadu, and malakriya. If these functions are normal, if these functions are within range for the establishment and life stabilization method, along with the last important word, prasanna atma indriya mana. Prasanna atma indriya mana, relaxed, conducive psych-physique of a person. So we have samadosha, we have samagni, we have samadhadu, and we have malakriya. Everything is normal. But if we are not prasanna atma indriya, means our senses, 5 senses, and all the activities of the 5 senses, which is not coordinating properly, then we have a physical normalcy only. We will not have any integral, the substantial normalcy. So the first samadosha, samagni, samadhadu, malakriya, along with the prasanna atma indriya mana, which constitute and create a healthy body. This is considered as the definition of a healthy person in Ayurveda. See, another thing, how we, in all diseases, generally the people used to ask how Ayurveda is diagnosing a disease. The people used to ask whether those days the coronavirus is not there, viruses are not there, then how we can able to contribute this information into the upgradation. See, Ayurveda is a very holistic approach. So even a compartmentalized approach we have, we always think very grossly. So all diseases, whether it is communicable, non-communicable, why we are debating this particular stuff? Because how these diagnostic tools or methodology is very much correlated, useful for the new pandemic. That also we're thinking in this particular slide. See, we diagnose a disease as per the 11 integral things: dosha, dushya, desha, kala, anala, prakriti, vaya, satmya, sattva, ahara. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11 is called bela. Dosha means the basic humoral. What we mentioned in Vada, Pitta, and Kapha, the basic humerals. That dosha, there is a methodology, there is a technique, there is an information, there is an informative aspects how we can able to know. Because lack of time, I'm not going very deep into that particular thing. Dosha. Second is dushya. Dushya I mentioned to you. The body is made out of 7 integral portions: rasa, rekta, mamsa, meda, asti, majja, and shukla, the sapta dhatu. And there is an evaluation method, and there is an upgradation method how we can able to see this sapta dhatu. That is called a dushya. Desham. Desham means the climate or the ambience. We have an internal ambience and we have an external ambience. External atmosphere of the human body and internal atmosphere of the human body. There are two aspects are there. So internal atmosphere has to be comfortable with the external atmosphere. That is called sammikavastha. That is particularly called sammikavastha. That is called desham. Desham means not the land. According to Ayurveda, it is the internal atmosphere of the human body and the external atmosphere, or we call homeostasis. Kalam. Because each diseases, whether it comes or goes, it comes in a particular climate. I told you, Grishma, Varsha, Sharat, Hemanda, Vasanta, all the Rudus are there. And how it is happening in each Rudu, and how it is moving off. What are the things we have to be taken care in each Rudu? That is, the disease is diagnosed as per the climate, and treatment is also recommended as per the climate. Because in a particular climate, this we have to do. Particular climate, this we wouldn't. All these are mentioning, or all diseases are explained by or diagnosed by the Kalam. And the next one is Analam. Analam means Agni. You may be heard about the Jadaragni or Dadwakini. This is correlated with the metabolism and Prakriti. Prakriti is same aspect of the column. But what is the Prakriti means we have a two type of Prakriti. One is the acquired Prakriti, that which develop as per we grow, that we get from our genetics. There are two type of Prakriti. One is that we acquired, that we develop through our movement in the future movement in the life. Vaya, it's very clear, it's an age. Satmya. Satmya means mind-body interaction. Sattva means mind and body in an integral method. Ahara means food. And Bala means strength. These are the 11 identification or 11 basic principles by which Ayurveda is diagnosing or Ayurveda is categorizing diseases. Next one, see, Ayurveda therapy, how in an upgraded level will benefit for this kind of a pandemic. Ayurveda therapies are able to produce, or ancient techniques therapy, especially the Rasayana, or we heard about the Panchakarma, are being accepted to accomplish the following goals of the treatment. What are the goals this Ayurveda therapy is aiming? The first one is strengthen the immune system. I will come later in a detailed way. There are a lot of controversies are happening in immune system. So how Ayurveda is perceiving it? That is strengthen the immune system. Second one is efficient detoxification system. Third one is responsive inflammatory system and optimal metabolic system. and balanced regulatory system, and enhanced regenerative system, harmonize the life force, free radical scavenging, or antioxidant activity. These are the basic principle by which an Ayurveda procedure is moving ahead. So there is a new concept in medicine is reaching. How this new concept of medicine is correlating with Ayurveda is mentioned here. In recent past, psychology has attained a significant role in area of disease production, and most of the diseases found having some psychological basis in their genesis. Thus, this branch of medicine that called the psychoneuroimmunology developed from the psychoneuro to psychoneuroimmunology, PNI, to psychoentoneuroimmunology, to psychoentoneuroimmune epigenetic status. See the development. Ayurveda mentions that, the body, the disease starts from the mind, then into the body, then it circulate or spreading into different system. So that's why psychoneuro, then it convert into psychoneuroimmunology, then psychoneuroentoneuroimmunology, then psychoentoneuroimmune epigenetic status. It's a level. So all diseases, it has got a huge connection with your mind. From the mind, it upgrades or it transfers into different mode, then it affects the entire your human system. The slow changes, that how the slow changes is happening, and what are the integral methodology or psychologically, anatomically, physiologically is happening, are getting upgraded. That already mentioned in Ayurveda in an abridged version. So what I mentioned regarding samadosha, samagnisha, samadhadu malakriya, that is slowly in merging with the psychoneuroimmunotherapy modules. PNI takes an interdisciplinary approach, incorporating psychology, neuroscience, immunology, physiology, genetics, pharmacology, molecular biology, psychiatry, behavioral medicine, and infectious disease, endocrinology, and rheumatology. So it became an holistic approach. Why I mentioned this thing? That the definition of Ayurveda itself is very interesting. Ayurveda is not a medical system. Ayurveda is a system that teaches the life. Ayuhu, Vedaha. There are two integral principles. Word Ayu means life. Veda, it means information or knowledge. It is the information of the life. So disease and treatment comes in the later phase. The Ayurveda gives how you have to live. What are the things is needed for a modest and comfortable life? What you should have to do, what you shouldn't do. What are the things you have to acquire? What are the things you have to move? What things you have to discard? So this is called a system which is teaching how to live. So once we have to debate on the system, how to live, then on that matter, we can able to discuss about the diseases and the rest of the things. Example, in a pandemic, why the pandemic is coming? What is the cause? How it is happening? Once we got it, and on that particular point, we can develop many things in future. See, there is a new word called seletogenesis. Most of you may be heard about or may not be. Seletogenesis is a new invention, new methodology in medicine. And see, seletogenesis is a medical approach focusing on factors that support human health and well-being rather than a factor that causes disease. There are, if you develop a disease, it's not mainly because of a pathogen. It's not mainly because of some pathophysiology. There are a lot of other factors are also happening. Because if you are diseased, if you are healthy, the disease condition immediately have to correlate with the well-being. If you are comfortable and stable, you have to correlate your condition with the well-being. So The important thing is that focusing on factors that support human health and well-being along with the pathogenesis. Example, what is happening now? We mainly focusing on pathogenesis. Okay, pathogen, we identify it. See, what is the mutation? How the mutation is happening? Because mutation is happening because of the logic of the virus. Our logic is entirely different than the viral logic. What we do, we want to make our logic into the virus logic, or we want to control the virus logic with our logic. And simultaneously, virus is not accepting our logic. Virus is moving with their its logic, and we are moving with our logic. Or what we are doing, we want to make the virus logic into our own methodological logic. So there is always a kind of a fighting mechanism comes. Can we fight against a virus? No, we can make a compromise with the virus. We can able to have an understanding, because virus is an organism and it is also living. We are also an organism, we are also a human being, and we also live in the world. And the same space also that creature has. Because once it invades, why? We provide an ambience. If we are not providing an ambience, that invader will not come into us. So the invasion of virus into our human system is not because mainly of pathogenesis. We create certain other things by which it is utilized by the pathogen to enter into our body. That particular thing is called the supportive human health and well-being, rather than on factors that causes disease. More specifically, the salutogennic model is concerned with a relationship between health, stress, and coping. We are not merely body. We are not merely pathological information. We are not merely anatomical information. We are not merely physiological information. We are something else than that. So the relation between the health, stress is coping. The term was introduced by Aaron Antonovsky, and a professor of medical sociology. Ayurveda is self-disciplined example of salutogenesis, because Ayurveda says, yes, pathogenesis is there, anatomy is there, or physiology is there, and there is a coordinating link with all these things. In certain a conducive coordinating link where all these ambience are created for an exogenous material to enter into our human body, we will liable for disease. And how we can able to collaborate, not to fight against with them, how we can able to resist, and how we can able to have more resistance in ourselves to avoid the entrance of that material into our site. This is called a conducive approach, or we call salutogenesis. Salutogenesis is going to be the highly debated and highly utilized medical information in future for all pandemic disease, all infectious disease. The salutogenesis in Ayurveda is called Swastha Vrutta. Swastha Vrutta. The same thing. Once again, I'm going to one of the last slide before the early slide that I mentioned to you, Samadosha, Samagnisha, Samadadu Malakriya, Prasannatmanendriyamana, Swastamite Vidiyade. There is a conducive relation between the system and the human being. And that is not merely because of the pathogenesis, it's not merely of anatomy, not merely of the human integral aspect. There is a coordinating aspect is also available. See, in Ayurveda, we mainly, if once Ayurveda comes in any disease format in debate, immediately there is a word, there is a typical word is coming, that is called immunity. See, Ayurveda immunity is quite a different way I'm perceiving. Because, you know, the what Ayurveda is doing during the time of a COVID, the people, if any patient comes or any information they want to have, immediately increasing the immunity. See, I doubt in my last 30 years of experience in medicine, especially Ayurveda, increasing the immunity is not the aspect of the medicine or the food that you eat. It is an integral part of your human system. Immunity has to be developed by the human system. We won't be able to increase immunity. If we increase immunity, immediately the viral load became aggressive. So what we will do? We will give immunosuppression. So once the immunity increases, the viral load is increasing, then what we have to do? We have to reduce the immunity. So if a medicine is given to increase the immunity, what is going to happen? It creates a disability. It creates a unequilibrated condition within the human body. So Ayurveda always thinks about in a word immunity, Vyadhi Bala Pradhirodhitvam. It's not merely Vyadhi Chamatvam. In Ayurveda, the particular term is called Vyadhi Chamatvam, is called immunity. That is created by the human body itself. We can only provide the ambience. Immunity is created by human body and we can only provide the ambience. Vyadhi Bala Pradhirodhitvam. Vyadhi Bala Pradhirodhitvam means called the Naisargika Vyadhi Chamatva against viruses is needed. So we give some rasayanas or some particular type of a medicine to increase the immunity. Whether the immunity is immediately increasing? No, immunity increasing in the body is decided by the body. So certain ambience we can able to create. That ambience is called a Naisargika. The original your body immunity is happening because of the Naisargika, the natural aspect. The immunomodulation means that not increasing, not reducing, stabilizing as per your genetic aspect or as per your body constitution is needed. Immunomodulation is needed, immunoregulation is needed rather than increasing the immunity or decreasing the immunity. That aspect is called innate immunity, where it is not achieved merely by some medicine or by some procedures, not by medicinal procedure, by which certain routine procedures. That particular conditions are the things are called dinacharya. So innate immunity comes under dinacharya, means daily routine. Ruducharya, I mentioned to you the seasonal routine. How to live in a day, how to live in a rudu. Brahma Muhurte Uttishtel Sustu Rakshartamarisha. This is the first shloka starting now. Brahma Muhurta. I don't feel how many of them are completely aware about Brahma Muhurta. Even the new generation or even our generation. How many of us have seen the sunrise? Even we don't know there is a sunrise. It's only became a poetical thing or became a debated thing only. How many of us are seeing or perceiving or interacting with the sunrise? Very little. Brahma Muhurte Uttishtel means you have to wake up in a Brahma Muhurta, which is a particular time. But whether it is happening? No. I'm not telling that you have to wake up in a particular Brahma Muhurta as per the standard climate. There is a time to wake up and there is a time to go to the bed. When you have to wake up, what you have to do, what you should not do, how long, what are the activity you have to do, how much rest you need, how much activity you need, each day, where, at what time you have to eat. All these things are mentioned. That comes under called Dinacharya. Next one is Ruducharya. Each season, this thing we have to do, this thing we shouldn't, because there is no extensive time for me. That's why I'm not giving. That will be a huge debate. So Dinacharya and Ruducharya is based on the three important things. One is called food, sleep, and exercise. We call in Ayurveda called Tristhuna, the three pillars of the human life. Pillars comes from the basement. The basement is the Tridosha, and the pillars are called this Tristhuna. Food, sleep, exercise. Food means Aharam. Aharam means Aharade the Ahara. That we consume, and that consumed thing became a body called Ahara. It's not the food. Whatever food that we ingest, that has to be conducive with our human system. That has to be with my physiology, anatomy, psychology, and even genetics. So food is a genetic portion. Like, the food that I enjoyed or that food, the particular food I'm eating is 90% is my genetic food. The way, the area where I born, the area where I am conducive with or accessible with a particular food, that is my genetic food. If we have a genetic food, if we have our own built-up food, and we move from one area to another area, we will transform. The transform is good. It is sociological transform or economical transform or facility transformation is happening, but the genetic transformation is not going to happen because I born and brought up with a certain food style. Immediately I changing the food style into another style. It has to be. It's a very important point for the food. See, why it happened in Wuhan? See, in the case of China, this is first reported in Wuhan seafood market. See, it's interesting. When we consider about the China, after the World War, there is a very huge famine in China. There's a scarcity in food. They started eating all kind of things. The thing that biting you, the thing that plan to kill you, that the human generation, the human race wants to kill and start eating. Whatever available that we are eating. So what food we ate, that became our body constitution. Or that became our body part. See, take the cases of the virus. The particular thing, after taking, we take a food and the excreta becomes, a waste became from the food. The food created waste in our human body is a waste for us. But for the viruses or any pathogen, that is their ambience to grow. So that is our logic, where we are dragging behind. Because what we see, our logic is that these are the things of waste for us. But it is waste for us. That is not waste for the pathogen. And the waste where we created in human body, we want to remove it. But the same waste where these pathogens are dwelling, where the pathogens are getting accumulated. So the waste that create, if it is more and more, it became the ambience for the virus. So the food that we want to have all food. If we start eating all kind of food, even that food is not comfortable for us. That became a waste product. That waste product, this virus or bacteria, virus, or whatever the creature, the pathogen, start growing. So discrimination and selection of the food is an important thing. You see the case of animals, you can say any creatures, they will take only the recommended, that accepted, the body constituent accepted food only. But the human being started having the food, even though that is not comfortable to our human system, we started taking it. That create a waste. That waste is not removed from the body where the viruses or any pathogens start growing. Second one is called sleep. Can modestly occupy our human body, we need an equilibrium. That equilibrated human level or human aspect is created by sleep. Example, why we sleep in the night? Even though we are sleeping in the morning time, we will not feel comfortable. Because the night is created for a good sleep where a certain hormonal neuronal mechanism is happening. Especially the serotonin, that hormone is not able to increase by medications. Serotonin is an hormone, melatonin is an hormone which is body created. We can only give an ambience to increase it. So the darkness stimulates the production of serotonin. The proper serotonin level creates a comfortable sleep. That's why we can able to sleep in the night comfortably. Even though we sleep in the morning time, in the daylight time, we will not feel comfortable. So sleep is sleep means it's not sleep. The timing of the sleep, the duration of sleep is an important. Nidra. If we want to go for a 7-hour sleep, a comfortable sleep without interruption, that sleep is the best mechanism by which our human repair is happening. All our internal repairs are happening because of the sleep procedure. If we get a proper sleep. Third one is exercise, Vyayama in Ayurveda. See, in the Vyayama recommended in Ayurveda as per the season. In the autumn season, in the spring season, in summer season, in winter season, you have to do the Vyayama up to this time because the climate and your body constitution and body has got an interaction. It has got a limitation. So exercise is an important thing. So the food, the sleep, exercise is balancing or modulating or model or making the internal, the chemical process of the human body in a normal way. Next one. See, previously I mentioned about the innate immunity. Now you know that adaptive immunity. Now, how we can able to have an adaptive immunity? Adaptive immunity by which Ayurveda play a bigger role. Innate immunity is by the work you have to do. Adaptive immunity, Ayurveda things and Ayurveda debate regarding with the medicament. These are the things meant for adaptive means sahaja vyadhi kshamata. The innate immunity I mentioned is the Swabhavaja. This is called Sahaja. What is that? Agni Devana means improving, normalizing intrinsic metabolic activity. Vadanulomya, the stabilizing vital forces in the body, especially the natural urges. We have a natural urges or the urination, defecation. All these procedures comes under the natural urges. We won't able to strongly, or we won't able to, in a wide scale, we won't able to obstruct it. We won't able to restrict it. We won't able to barricade it. The natural urges, once it comes, it has to have an eliminative thing. It has to have a passage. But see, most of the natural urges is one way, another way is getting obstructed because our work culture is not related with in compensating with or in supporting with the natural urges. Once it comes to the Vada Anulomita, Vada, the integral principle of the human body is not functioning normally. So once the natural urges are blocked, the Vayu get obstructed. So the Vayu obstruction is reducing, or Vayu obstruction is disabilitating or the integral immune system. The third one is called Ojaskara, improving and normalizing required nutrition to the body with scavenging activity. And Srodho Shuddhi, stabilizing and removing the obstruction in the essential channel of the body. And Sandarpana, means enhancing. Sandarpana means improving, enhancing your body functions, enhancing the fatty metabolism, discriminating the metabolites. And the sixth one is called Lenghanam, called higher the level of fat and carbohydrate, Lenghanam bring into the normal level. Lenghanam means restriction. Brahmana means increasing or utilizing the nutrition into different part of the human system to stabilize it. Lenghanam, okay, even maintaining the nutrition, if certain metabolism is increasing, like fat metabolism, carbohydrate metabolism, there are certain procedure by which the metabolism has to be happen in a normal level. It should not go increasing. Or what are the things is increasing the metabolism? What are the things is disfiguring the metabolism? That things has to be considered in the Lenghanam. And seventh one is called Rasayana Karma, or antioxidation and scavenging, which I come in the last slide. See, exaggerated, I want to mention, I want to discuss this subject now. Exaggerated concept about immune enhancing or immune increasing. See, Vyadhi Kshamatvam, immunoregulation, the substance modify immune response endogenously and exogenously. They can enhance a response or surpass. Can achieve through Dinacharya, Ruducharya, and with the minimal medicines. Vyadhi Bhala Pradhirodhata. Initially, I mentioned that natural immunity, the immunity created by the human body, that we won't able to inculcate or increase or decrease with certain other means. That is made by the natural procedure called Dinacharya, Ruducharya, and selective medicine from Dinacharya and Ruducharya is increasing your Vyadhi Kshamata, means the immunoregulation. Vyadhi Bala Pradhirodhitam is body's innate procedure. Vyadhi Bala Pradhirodhitam is body has to decide to improve and stabilize the immunity. Ambience for immune enhancing done through the Swastha Vritta Charyas. There is no ahara vidhi to increase immunity or Vyadhi Bala Pradhirodhatam is decided by the body. Nutrition of the human being, Anna Samskaraniya, differ in nutrition of the microbe, which I mentioned to you earlier. What is the waste for the organism is not waste for us. What the human waste, that waste became an food to the organism. What the waste created by the organism became a disease to the human being. So we have to have a very good information, very good innate knowledge regarding with the food. Whatever we use is not going to be your body integral portion. That create an waste mechanism. In the waste mechanism, the microbe starts growing. Attitude need to deal with virus. Now we are planning to have vaccines, medications, and a lot of things are debated. Still now we are nowhere in a reaching goal. Maybe it will be near to us in the coming days, but how long? This is a debate is going. So before the virus vaccine reach, before a specific medication is reached, what we need to contain this virus? We call it is a natural rasayana. Ayurveda says dhirada or courage. Courage is the vaccine. Courage is not a particular entity. Courage is an attitude. And second one is called samikshagari, a reviewer than panic inculcating. Samikshagari means we have to understand what discriminately we have to do, what we should not. Once the samikshagari bhava is moving from our side, we are overexposing. Once an aspect comes, we are overreacting, overexposing. This overreacting, overexposing create a panic situation. So we have to have a samikshagari bhava. Samapara, samabhava, balancing mind that normalizing the body. We have a balancing mind system by which only body is getting normalized. Nirukti. We want to know the definitions of the patterns, definition of the particular thing. So once you think about Ayurveda, once you want to interact with Ayurveda, that time you have to think about the definition. That I mentioned you previously. Ayuhu Vedaha. Ayu means knowledge of life. Ayu means knowledge. Veda means life. It is knowledge of the life is not a system or is not the medicine provided system. It gives you information about how to live, what to do, what should not. Third one is called yukti, which I mentioned. All entities in the universe has got logic. Imposing logic will diverse from action. Viruses has got its own logic. We have our own logic. Bringing one's logic to our side will not bring solutions. Understanding logic followed by bringing mutual solution is useful logic or practical logic. So, according to Ayurveda, what is logic? The logic that we have is different than the logic of the virus. So, to understand the logic of the virus, to prevent it, we need certain precautions. Mask, social distancing, regular hygiene, courage, all these are our logic, which is applied to be away from the disease. Integral need and basic attitude of a medical person. See, here we will debate regarding with the patients. What is an integral thing needed for a doctor to enact with this kind of a situation. That is mentioned in Ayurveda, that is called Eka Shastra Madhyano na Vidyad Shastra Nishaya. Tasmat Bahusudha Shastra Vijaniyad Chikitsaga. Who is a Chikitsaga? Who is a Vaidya? Who is a doctor? They should have to have information about other streams of medicine, other streams of science than only can be named as Vaidya. Because if I know only my stream of medicine without any information about other streams of the sciences, the particular doctor is called in Ayurveda called Kuvaidya. We want to know what other system or what other branches of the sciences are thinking about it. So inculcating with the parallel contributive branches of the science is an integral important thing for the sustainability of the human life against this kind of a monster virus. I told about you the Rasayana. Certain few thoughts to the scholars, the students, the academicians who watching the program. I'll give certain hint. Rasayana is an important immunoregulators in Ayurveda. But certain innovative and inculcative methodology is very much needed. So thoughts for the PG students, research scholars and institutional project. Those who want to have an institutional project. First one, effect on increasing macrophages activity. How Rasayana is doing the increasing macrophages activity. This we need to have a study. Second one, increasing efficacy of T cells and B cells of adaptive immunity. How it can be achieved by Rasayana. Third one, reduces cytokine storm reasonably. With the help of the Rasayana, how we can able to, or is there a possibility to reduce the cytokine storms? Fourth one, abort the linkage of the spike protein of SARS coronavirus 2 with the host cell ACE2 in receptors by blocking entrance of the virus. Because this virus is entering into human body by the host ACE2 receptors. The protein spike of the coronavirus is attached to the ACE2 host receptor. And if we provide the Rasayana, we can able to arrest the linkage, or we can able to have a negative mechanism by which the receptor is not interested, not able to receive the spike protein, or spike protein is not able to interact with ACE2. And whether this thing can be achieved by Rasayana, this is a food for the thought. Fifth one, reduces inflammaging in old age people. There is a word we use in medicine called inflammaging, especially in older people. What is inflammaging? All older people, older generation, whether they are timely healthy, there is a little bit of inflammation is happening in their body because of the degenerative procedures. Even they are fit, there is a degenerative procedure is happening naturally. That degeneration creates an inflammation recurrently always. So those who are having an inflammation which is caused by external objects, with some infection they are getting inflammation. Simultaneously, they already have their own inflammation in the body because of the age advancing. So Rasayana can able to reduce the body built aging mechanism. That is an important thing, because Rasayana used on those days reduce the aging. It's not a philosophy, it's not a poetical meaning. Reducing the aging with Rasayana is not considered as a poetical feeling, because how the aging is reduced means reducing the natural degenerated inflammation in the body. There is a natural inflammation happening in the human old generation, in geriatric people. And that inflammation, the Rasayana can able to reduce or minimize. That's an interesting subject for the future thought. Can enhance the span of antibody. Because another problem, once we get a vaccine, Before the vaccine, the vaccine, the antibody that we inherit, the antibody we inculcate in your body, how long it will last? Whether it will last only 20 days, whether it lasts for 1 year, whether it lasts for 5 years, we are in the study aspect. We are only in the first phase of informations, because this is a new virus. We don't know how it is happening. So the antibody that is we got, this Rasayana can able to enhance the antibody for a long time with the help of a vaccine. Even with vaccine, this antibody can be enhanced. So there is a collaborative methodology of Rasayana given to the patients who are taken the vaccine. Or in absence of vaccine, how long we can able to extend the quality and the quantity of the antibody. How bioenergy principles are reducing viral load. Because the Rasayana, especially in Ayurveda, material that we use is an herbal material. So all these herbal materials or the herbal ingredient has got a bioenergy. Example, we use Revolfia serpentina in a crude form. We extract the alkaloid from the Revolfia serpentina. The alkaloid extracted from Revolfia serpentina given to a patient, and the crude form of Revolfia serpentina given, it functions entirely different. Because once we extract the alkaloid is going to the human system, and the side effect of the alkaloid will come. In a crude form, the alkaloid is there along with the potent material that which the alkaloid side effect will be minimized. The crude form is reducing the side effect of the active principle. But once we extract the particular thing, that particular thing which has to be there to reduce the side effect will not be available. So that bioenergy principle means even though once we give a plant medicine, once we give any medication, because with the help of the bioenergy, can be able to reduce this this bioenergy principle methodology will reduce the viral load or not. This is a food for the thought for the future researchers and scholars. And see, this is an intentional slide I want to show to all this, especially the students. And most of the students, especially from the branches of biotechnology or microbiology, want to do certain project and program. They will select a certain Ayurveda medicinal plants and Ayurveda ingredient for the research. The researchers needs following, because 78% depends upon the plant product as medicine. For all these things, you need history. If you select a medicinal plant for a virus, for a pandemic virus, you select a medicine from the Ayurveda thought process, and you are developing it. Well and good, everything is accepted. But you need a history. From where you get an history? You get an history from the traditional knowledge and information. And third one is habitat. The particular medicinal plant you want to utilize for this one. And it's so difficult for you to tomorrow you can able to cultivate in a particular area. That plant has got an history where it is properly grown. So habitat you will get from the from Ayurveda. History you will get from Ayurveda. And chronological evolution, what is happened in medicine, because nearly 2 lakh medicinal plants are mentioned in Ayurveda, and most of them are extinct, and most of them, the few of them are not able to identify it. And so all these medicinal plants or the Ayurvedic medicine that produced from years onwards, the chronological evolution happened. Documentation in Samhita and manuscript and palm leaf. Most of the things are documented in manuscript, the Samhita, and that became a carrier guide for the new researchers. Standardization of the medicinal plant and medicinal medicament, folklore and ethnobotany, science value addition. The scientific value addition is an important thing. You focus on a particular thing, that particular aspect has to value added, then only the utility comes. So this scientific value addition points, you can get it from the traditional medicine. All these relevant points will merge out from tradition, practice, and evidence. See, in the case of an Ayurveda, who is a doctor? What is the responsibility of the doctor? That is mentioned by Charaga. The duty of a Vaidya not to giving or adding medicine or medicament, but to educate and transfer the knowledge to the common mass. So transferring the message to the common mass is an important thing during a pandemic. Than medication, we need to have an informative transference is needed. The same thing is mentioned by the father of the modern medicine, William Osler. One of the first duty of a physician is to educate the mass, not to take a medicine. It's not to write the medicine first, more than that, educate. Education itself creates a lot of strength and away from the panic of this thing. So that create a positivity. Why? The research is very good, because whatever we researched out, whatever we got from 1,000 or 1 lakh, 2 lakh cases, that we are going to implement into the new patient, because the age new patient is totally different than the last 1 lakh. So each individual is a medical textbook. So we have to approach in the time of pandemic to each patient in a very innovative information and knowledge. Medicine is a science of uncertainty and art of probability. This has to be taken care by all the persons involved in this particular thing. And this is again the word by William Osler. So thank you all. You were given a wonderful opportunity, because I know such a very range of the scientific innovative speeches. My duty is to give you certain tips or give you certain information that Ayurveda is last many years is carrying with us, that we can able to contribute. So in a pandemic time, working single is not going to be benefited. Working together, all allied branches stay together. There may be some scratches. The scratches has to be polished. The scratches has to be properly delimited and create a new methodology. So coming together is a beginning. So we are in the beginning, because a pandemic created a togetherness feeling. Coming together is a beginning. A pandemic creates a beginning. Keeping together is a progress. The pandemic in future, our future thought provided a progressive togetherness. Work together is a success. The coming together is a beginning. Pandemic had given that information. Keeping together is a progress. Pandemic had given that progressive approach. And working together is a success. That success will create and that success will eliminate this monster virus from our day-to-day procedure. So festivities are coming, festivals are coming. So the lockdown is gone. Restrictions are slowly reducing, but still the virus is with us. And we won't able to, the particular word I used, we won't able to fight against the virus. We want to have a compromise, because like us, virus is also having a logic. Our logic and their logic, they're going to be a compromise. The compromise comes because the virus it's a virus also need to survive. For the survival, what it will do, it will reduce its replication. Once the replication comes down, the mutation also will come down. So we are expecting it. The mutation comes down, the replication comes down, the viral load is coming down. In that time, we can expect a vaccine, but still the vaccine is in a research condition. We are quite away from vaccine. Whether it comes today, tomorrow, only hope has there. But we have to live with the virus. For the living with the virus, we need togetherness, we need progress, we need together success. And I'm thankful to all the organizers, the participants, the researchers, the scholars, and I'm very thankful to hear from my side, and we will meet again. Till then, goodbye, Dr. Jayachandran.
Hello.
Yes.
First question is, nowadays people use home remedies to protect against coronavirus.
Okay.
Know how much amount is taken and timing also. So please explain some Ayurveda remedy that is in the epidemic.
The voice is getting dribbled. Hello. Hello. Hello.
Hello.
Yes, the voice is getting dribbled. Can you say once again, please? Hello. Yes. Can you say once again? The voice is dribbling.
Nowadays, is it clear? Hello.
Yes, yes. Tell me. Tell me.
Sir, nowadays people use home remedies to protect against coronavirus, but they don't know how much amount is taken and timing also. Please explain some Ayurveda remedies that help us in this epidemic.
Okay. See, in my speech, I mentioned about the remedies are in the two types. One is our practices and certain medication. First, I'll tell about the practices. Important thing is that waking up at a proper time, going to bed at a proper time, have food at proper time, and have avoid the constipation, and select the food that is comfortable to you. The food that is not comfortable to you, because of your happiness and cherishness you go for, that will create a bad thing in this particular climate. And regarding with the medicine, I told the Rasayanas. The government of India, I'm thankful to government of India because government of India had given with a lot of encouragement this time. There are certain standard medications we give to prevent it. One is the simple one is called ashwagandha. Ashwagandha is considered to be one of the finest immunoregulator. How much is the quantity? I'll tell you. 5 grams of ashwagandha. If you take ashwagandha directly with water, sometimes it will take time for digestion. So what we have to do, ashwagandha 5 gram has to be mixed with milk. What kind of a milk? That's an important thing. Example, if you take a milk, all milk, the ashwagandha powder will not mix properly. So if you take a milk 20 ml or 50 ml, how much you need? 50 ml, you take it 1 teaspoon. If it is diluted in 50 ml, 100 ml, it's not a problem. We can go dilution up to 100 ml. So if you take 50 ml of milk, add 50 ml of water, then reduce into 50 ml. That will give an ambience for this ashwagandha powder to dilute properly. In that milk, you take this one morning after food and evening after food. This will create energy. This will improve your metabolism. This will create an antioxidant activity. First one is this ashwagandha. And second one, see, I have a humble request. There is a good practice. It's a good practice and very effective practice, but restriction should be needed. The people used to mix the haldi powder with the milk and mix it and take it. See, if certain people has got a strong allergy against haldi. So haldi powder has to be mixed with water and take regularly. It should not going to be a routine without the suggestion from an expert, because it is a medicine given by the Vaidyas or the physician. Your body constitution and body characteristics are very important. So those who are not having allergy for the turmeric and milk can have it. Those who are having should not take that one. And the third one is there is a combination called Indu Kandam. This is a classical Ayurveda medicine called Indu Kandam, which contains Dashamula, Daru, and Haridra. It contains 13 medicine. This comes in the decoction form or the kwada form or the water prepared form. And it comes in the crude form. Like, all these medicines are prepared in a powder form. If you are taking the powder form, take 2 teaspoons of this particular powder, means 10 grams, put it in 100 ml water and gently heat and reduce it to 60 ml. and take this 2 times. So Indugandham Kashayam, Haldi powder discriminately, Ashwagandha, and very simple thing, Tinospora cordifolia, that is called Amrita. You put it in a little lukewarm water and heat it and take it regularly. This also benefit, and these 3 things are recommended and it is already documented, and this will improve your resistance during the pandemic time. Hello. Any other questions, please?
Sir, thank you very much for your valuable speech. Because of the time constraint, we need to stop it.
Correct, okay. Correct. I'm also having problem because it is during the lunch time. Extending this questionnaire session will create a problem for your stomach. Hello? Hello? Hello?
Is it audible, sir?
Yeah. Audible.
So thank you very much for educating all of us on the alternative medicine and how it should be taken and the rest of the things. Thank you.
Thank you very much.
Now, an important announcement to be made before I propose the vote of thanks. That is, all the participants, I request all the participants to send their feedback forms. Already, the link has been sent to your registered email addresses. Okay, so I request all of you to please fill the feedback form and send it to us. And then after sending that, you'll be receiving the certificates. Just a few minutes. We'll be going through the posters that are compiled by Gujcost in order to bring the awareness on COVID-19 infection. Please, maybe a couple of minutes. See, this is made in local language for the benefit of common man. Okay, let me propose a vote of thanks. First of all, we would like to thank all those who are involved either directly or indirectly in the successful completion of this webinar. On behalf of the organizers of this webinar, we thank our Honorable Chairman of Sarvidyalay Kelwani Mandal Kadian Gandhinagar, Shri Sardar Vallabhbhai Patel, for his continuous support and constant encouragement. Thank you, sir. Then we thank Professor Gargi Rajpara, the director of Kadi Sarva Vishwavidyalaya Gandhinagar, for for her encouragement and continuous support. Thank you, madam. We don't have enough words to thank Dr. Narottam Sahu, the advisor and member secretary of the Gujarat Council on Science and Technology, Gujcost, the government of Gujarat, for his enduring help in organizing this webinar. Thank you very much, sir. We also thank the team of Gujcost for their help in popularizing the awareness on coronavirus. Then we thank Dr. Kalpesh Panchal, MD pulmonologist in Swastik Lung Care and Allergy Clinic, Ahmedabad, for increasing our awareness on the coronavirus. Thank you, sir. Then we thank Dr. Madhvi Joshi, Joint Director of Gujarat Biotechnology Research Center, for educating us about the COVID-19 genomics, its uses and applications. Thank you, ma'am. Then we thank Dr. Dilip Zaveri, Director Biocare Research Private Limited, Ahmedabad, for sharing his vast experience and knowledge on different diagnostic tests of COVID-19 infection. Thank you, sir. Then we thank Dr. N. Jayachandran, Ayurvedic physician, Ahmedabad, for enlightening us about the alternative medicine in combating COVID-19 infection and related infections and clearing our myths about the infection. Thank you, sir. Then we thank the Registrar of Kadisar Vishwavidyalaya, Gandhinagar, Professor Surya Krishna Mantrala, for his valuable sessions in organizing the webinar. Thank you, sir. We thank Professor Keyur Shah, the principal of Sri Maniklal M. Patel Institute of Sciences and Research, for his everlasting support and advice. Thank you, sir. We thank the entire management of Kadi Sarva Vishwavidyalaya, Gandhinagar, for their support in organizing the event. And thank you, sir. And we thank all the principals, directors of our constituent colleges for extending their support and good wishes. Thank you all. Then we thank Dr. Haider Ali K. Ansari, the technical head of Kadi Sarva Vishwavidyalaya, Gandhinagar, for his valuable support in organizing the event. We also thank his associate, Mr. Dhaval Pandya, for extending the help. Then we thank Professor Hiren Patel, Principal of Vidush Sumani Institute of Technology and Research, Kadi, for his contribution in successfully organizing the webinar. Thank you, sir. We thank all the participants for registering and attending the webinar and making it a grand success. We thank the students and entire staff of the Department of Biotechnology and Microbiology of Sri Maniklal M. Patel Institute of Sciences and Research, and they are also involved in organizing the webinar. Thank you. We are thankful to our team members, Dr. Anjali Padiyar, Dr. Falguni Patel, Mrs. Archana Tripathi, Mrs. Gayatri Patel, Dr. Bushra Zarullah, Dr. Akruti Joshi, Ms. Megha Patel, and Mrs. Parulika Patel, who helped us in organizing the webinar. Without your help, this event would not have been organized. We thank Mr. Ankit Karadi, one of our alumni, and his associates for their help in the execution of webinar. Last but not least, a special note of thanks to Dr. Lakshmi. Madam, without your contribution, this webinar would not have happened. We thank you very much for your effective planning, efficient organizing, and successful execution of the